occurs more on the femoral side than on the tibial side. If it is placed too posterior, it will lead to the extra stress in extension, and if it is too anterior on the tibial side, it will lead to extra stress in flexion. Similarly, the tibial tunnel has to be at the tibial footprint. If it is not placed properly onto the footprint, onto the tibial or femoral side in the sagittal and axial plane, it can lead to the impingement and ultimately rupture and failure of the graft. So we know the footprint position while we are scoping, and we have to make sure that it goes where it is supposed to be. Another factor which can lead to the failure of the graft is the inadequate tensioning of the graft. If you don't tension and remove the laxity of the graft, it will stay lax peroperative as well, and you can have that feeling of the laxity right there and then once you are testing it after fixation. Or the graft can have a creeping effect and can be intact fixation wise, but still can be lax and will not perform the proper function which it is supposed to. The placement of the screws, if you are using the bone patellar tendon bone type of facial reconstruction, or using screws to fix your hamstring reconstruction, if the screws are not placed properly, they can pinch and damage the graft while you are positioning those screws inside the tibial or the femoral tunnel, both the ways. कुछ थोड़ा सा लैग आता है मेरे ख्याल में इसमें. Another technical factor which can damage the fixation of graft is the femoral tunnel blowout, which will not allow the graft to be fixed properly. If your offset is too less, or if you have not positioned the knee properly, the reamer can cut through the femoral cortex and can damage not only the femur on the cortical side, but it can have a poor effect on your graft fixation on the femoral side as well. An unrecognized problem which can happen in these patients, which can lead them to have poor stability after reconstruction, is missed initial ligamentous injuries, which can cause the extra stress onto the graft. And the commonly mixed injuries are corner injuries, posterolateral, posteromedial corner injuries, or medial or lateral collateral ligamentous injuries in isolation. Or if there is an associated PCL injury as well, it's a multi-ligamental injury which can cause the secondary instability and can damage the graft. The alignment issues are important as well, because alignment issues can be there to begin with, which were not evaluated properly, which led to the rupture of ACL, the native ACL in that particular patient to begin with, because all the people who are involved in the same activities, they don't rupture their ACLs even if they are put into that extra stress. But some of them fail, not all of them are failing, which leads one to think that is there something wrong in these patients inherently which has led to the failure of their native ACL, in addition to exclusively labeling it to only and wholly and solely to the traumatic event. So that must be ruled out before one thinks of attempting the ACL reconstruction to begin with, because if that factor is not looked after during initial reconstructive phase, that will persist and will definitely lead to your well-fixed, hard-worked, properly placed graft second time as well. So the alignment issue has to be taken care of. For that, one can ask for the alignment views, as we know. So what matters ultimately is that why this initial graft failed to begin with, why this initial ligament ruptured to begin with. Was there any factor which was there which led to the failure of this native ACL, or it was the force which led to the failure of this cruciate ligament? And why it has failed second time? Is there something extra which has happened? Because we know that as these patients remain deficient in their ACLs for a longer period of time, the stress onto the limb changes, the mechanical axis changes, the weight bearing axis changes, and the slopes alter. So one must cater for all those anomalies to be there before thinking of revising that anterior cruciate ligament which failed earlier. So you need a detailed examination focusing on the gait and stance, knee stability tests, definitely anterior and posterior draw tests, pivot shift tests especially, and varus and valgus stress test on the physical examination. On templating and workup side, you need to have proper views to see in that initial fixation. Was there anything wrong with that initial fixation, or was it done optimally as it was supposed to be, or has there anything happened to the bone? Has it changed its anatomy as a result of this prolonged ACL deficient knee? CT scan can be a very helpful tool in these cases because that will tell you what is happening inside the tunnels in addition to the bony anatomy, because now we know that more and more fixation devices are being used, which includes the absorbable devices as well, and we know that the tunnel widening is one important portion of these absorbable devices which we are using, because the body generates extra inflammatory response, and that can lead to not letting that graft incorporate and can widen the tunnel and can result in the failure of the graft. So that you cannot evaluate on just simple plain X-ray. You need to have a CT scan to know what exactly has happened to the tunnels after the fixation, because then you need to devise your strategy accordingly. MRI is definitely if there is something additionally happening in addition to the ACL to the menisci which were there. Were there any injuries to the meniscus, medial, lateral, roots, or anything extra which has happened to the other ligaments as well? So what are the graft choices? Once you are thinking of revising an ACL, you must think that what are the graft choices which are there, because one portion of the probable harvest has already been taken. So then other options which are left are autografts and allografts. Allografts are not available with us at the moment. So autograft options are on to the bone patellar tendon bone site, the bone and patellar tendon bone ligaments, hamstrings, quadriceps, along with a piece of patellar tendon, peroneus longus, Achilles tendon, or tibialis anterior posterior. We in our center are not doing the tibialis or Achilles tendon. We are doing peroneus hamstring and definitely the bone patellar tendon bone based reconstructions already. Another factor which has to be considered, is there some way that by which we can avoid taking all that previously which was put in and still do the ACL revision, ACL reconstruction onto the same knee? Because if these screws are very well fixed, we know that they are not very easy to take them out. And if they have been already malpositioned, so you don't need to actually bother to go and take them out. So you can place your tunnel safely if there is a window available into the proper position and can still bypass all the previous reconstruction which was done. So for that you need the proper evaluation with all the imaging available with. The tunnels, if they are expanded, definitely you need to take everything out. refresh them and graft them, because the staged reconstruction is the way forward for such cases. While doing the revision ACL reconstructions to handle with the tunnels, you can take the graft very easily out and can refresh the tunnels as well, but putting the graft is a bit challenging and technical as well. But there are devices available by which you can take the core of the tunnel out and can take the core from the iliac crest or some other portion and plug it in, and it stays, if it is taken properly, inside. Otherwise, if it is not properly taken and the tunnel is too wide, it is going to fall out every time you are trying to push it and place it in, because you are using the water flow through your scope, and it is not very easy to place the graft in a flowing water stream, especially if your tunnels are wide enough. We normally do the staged reconstruction in such cases in which tunnel widening is there. We take out everything, graft it, and wait for 3 to 6 months till the graft is taken very well, and then do the reconstruction in the second stage. So these are some of the indications for the 2-stage ACL reconstruction. You definitely need a more careful, planned rehab protocol for your revised ACL, because now it has become even more precious. And we know the results of revision ACL reconstruction are definitely, no matter what you do, are much inferior than the original native first time attempted ACL reconstruction. So that plan has to be chalked out properly according to the patient. So in conclusion, recognition and treatment of predisposing factors which are there normally in some knees which led to the failure of that graft should be looked after, because the eyes do not see what the mind does not know. So one has to identify all those factors which could have led to the failure of the previous original native ACL and which has led to the failure of reconstructed ACL. Identifying those factors, sorting them out, planning well can lead to the much higher chances of success. That's it. Thank you.
So any question? Hello? Any question? So if there is no question, I can move to the next topic. Thank you. Thank you. Next is free papers, and that is by Dr. Zain Mahmood, role of combined arthroscopic MPFL and lateral retinacular release in lateral patellar instability. Dr. Zain Mahmood. So if the Dr. Zain Mahmood, if he is not present, I will move to the next topic. Dr. Faiz Ali Shah, arthroscopic anterior cruciate ligament reconstruction, a paradigm shift in patient's perspective.
Bismillah ar-Rahman ar-Rahim. So, The topic of my presentation is anterior cruciate ligament reconstruction, a paradigm shift in patient perspective. Disclaimer, I have no conflict of interest and no grant support received. Knowledge isn't free, you have to just pay attention to it. The outline of my presentation would be learning objective. I will be discussing shortly the learning objective, learning outcome, background of my study, then the study objective, the rationale of study, then the methodology, results, discussion, conclusion, recommendation, and limitations. Learning objective. By the end of these presentations, the audience should be able to know patient information and understanding ahead of arthroscopic ACL reconstruction based upon the finding of a cross-sectional descriptive study. Outcome. By the end of this presentation, the audience should be able to conduct similar or maybe better studies on this topic in their own setup. Now, what is a paradigm shift? A paradigm shift, it's a definition, a major change in worldwide view, concept, and practice of how something works or is accomplished. So we will be, I will be telling you the patients, how the patient perceive ACLR arthroscopically, their background knowledge when they came to you for treatment of ACL. It is estimated that 28% of patients are dissatisfied after anterior cruciate ligament reconstruction, in part because they do not understand the procedure well enough. It has been documented in literature. Now, if you see ACLR has a long history, and the history dates back to the old Egyptian time up to the present time. And there are certain controversies or stages. Initially, there was a debate that whether open or arthroscopic when arthroscope was not available. Then the choice of the graft, then the use of synthetic materials. So all these have been controversies, and with the passage of times, the debate was going to be solved. Now, as you can see previously in the initial stages, this was a debate that which procedure, open or close. And especially in Pakistan, where centers still they don't have arthroscopic, so many of surgeons, they perform open arthroscopic ACL as well. But you can see finally the circle is closing. This is a study of 20-year follow-up. The largest study up till now on ACL reconstruction arthroscopically, and beyond doubt, it is proof that arthroscopic ACL reconstruction is the gold standard now. So that one controversy is solved now. Study objective. We performed this study, it was a just patient perspective arthroscopic ACLR by determining the prior information of arthroscopic ACLR. The rationale, why we perform these studies. As you can see, in many other specialties like gynae, like vascular surgery, ophthalmology, this subject has been well addressed, that pre-operative patient information. Even in orthopedics, if you see several studies in orthopedics, general and prosthetic studies are there, but no study especially from Pakistan, on patient's perspective of ACLR has been done up till now. So that was the main rationale for conducting this our descriptive study. And without good quality information, the patient is less in a position to contribute decision making or to provide genuinely informed consent to the proposed treatment options. Arthroscopic ACLR is a relatively new concept in many centers in Pakistan. As I've told you already, no study has been reported on this topic in Pakistan. So this was just a cross-sectional study, and we performed it at Lead Reading Hospital, Peshawar, in the year 2022 to 23. And methodology was simple, the inclusion, all adult patients that are for ACL reconstruction, that are diagnosed clinically as well as with MR confirmatory, and exclusion or revision or failed surgery. For each patient, we just make a pro forma of 12 questions, and we asked those questions from the pre-op patients when they consented for ACLR, and we rank those questions from 1 to 5 on Likert scale. This is just a pro forma which we use to collect our data. As you can see, simple questions regarding ACLR: is there less bleeding during surgery, reduced risk of complication, shorter recovery period, smaller post-op scars, fewer stitches, less pain after surgery, diagnosis and treatment and one surgery, minimal trauma to the LD, prompt rehabilitation, and whether it is economically feasible or not. And their response were ranked on this Likert scale. So results, we have collected data of 80 patients, all were male. The mean age was 34 years. Right ACL was ruptured and majority of the patient, and majority of our patients were educated, that is intermediate and above. Competitive sportsmen were 17% and casual sportsmen were 13%. So most of our patients strongly agree that ACLR would result in smaller scar and fewer stitches and less pain after surgery. This was the main finding based upon their perceptions or their pre-op knowledge, and that is collected through our data collecting tool, that is questionnaire. About 75% of patients strongly agree the ACLR would result in reduced hospital stay and prompt rehabilitation. Majority of our patients neither agree or disagree regarding the reduced risk of complications, diagnosis and treatment in one surgery, and minimal trauma to the LD tissue. They were not sure about these questions. A large number of respondents strongly disagree that ACLR is economically feasible. Their pre-op knowledge, they know that it is a costly, might be using fiber wire, fiber tape, suture anchors, so that are economically not feasible to most of them. Some patients strongly agree that arthroscopy was recommended by other patients. That's another finding, that they have been asked or they have been advised arthroscopy by other patients. Majority of competitive sportsmen have accurate and uniform response rate, followed by casual sportsmen, educated patients, and other, and that was statistically significant. Meaning that it means that sportsmen, they have a better or good knowledge, and all the sportsmen, though a short sample size, they have a uniform, almost uniform response rate based upon our questionnaire. Now, if we look into the literature, we just little bit of literature search. So even in developed countries, the pre-op knowledge of ACLR was not up to the mark. As you can see, in this study, that the number of respondents, 37% of the patient have no knowledge of ACLR, 49% have little, 58% of moderate, and only 64% of they have considerable or extensive. Conclusion. So based upon our study results, our patients' knowledge was variable. Small scars and fewer stitches, less pain after surgery and reduced hospital stay, and faster return to work or sports were the main reasons for selecting and preferring arthroscopic ACLR by majority of our patients. Competitive sportsmen have better knowledge of arthroscopic ACLR than others. We recommend that whenever a patient with ACL repair, they consult you for their surgery. So oral information about ACLR should be given to them by arthroscopic surgeon, and since physical therapist is involved, a part of your team, so he should also give relative information about the ACLR. Other sources such as validated brochures, including recommended web base could improve patient information. And most importantly, if you have in your data patients that you have operated, they are a better example to motivate or educate further other patients. Our study has some limitations. The questionnaire which you use, it was not validated, and patient information sources was not determined. We couldn't find, rather it was not our objective of our study, that from where the patient got those information, how they decide that arthroscopy is better and how they answer our question based upon their received information. These were references. Thank you very much.
Faiz?
Any question?
Yeah, just a quick one. Faiz, you said that you have 80 patients in the study included. How many of them actually got the surgery done after explaining or knowing the procedure, or what was the percentage of patients? All of them.
Actually, the inclusion criteria was that patients who are willing for ACLR.
That's very
yes.
good. So they were all operated.
Yes,
And
they were all
Yeah,
operated.
my supplementary question is that 80%, around 80 patients, 30% of them, they were playing sports. The rest 70, they were not playing in sports. What were your indication for doing arthroscopic ACL reconstruction in those 70% patients who are 34 years of age and who are non-sports people?
Yes, they were just sedentary, like office worker. Sportsmen, we have particularly small portion of our sample size were sportsmen. The other was students, but not actively doing sports. Office worker, business worker, shopkeepers. So that was our data. The sportsmen, actual percentage of sportsmen were small percentage.
Hello. Okay, so I think I got what Sami was trying to get is for someone who's not a sportsman and he's in his mid-30s, why you want to do an ACLR in that group of patients? Is that what?
That's right. That's another way to put my question.
Okay, so
Yeah.
that was he was trying to get. So let me answer him because
Okay.
in Pakistan we've got kind of a different scenario. So most of these patients are overweight, okay, and they have an instability mainly, which is causing them to have a constant pain. That is one of the indications.
Yes.
Hello? Okay. So that is one of the indications. Although I still feel that those patients should be referred to physiotherapy first and have a good rehab. And out of those patients, those who failed the conservative measures can be offered a reconstruction based on their symptoms. So that's what actually happens. So not everyone goes down to that road, but it's kind of a different thing. Is that right, Sanallah?
Yes. Thank
Yes?
you.
Yes, yeah.
Thank you.
I would like to take Professor Zaid Askar's opinion on this.
Well, I think the indication of surgery in our circumstances is slightly different to the West. Majority of the patients which I operate on it, and I have got no bar of age on it. If the patient comes to me with a history of instability, he's not sure about his knee and is clinically unstable, and it's causing him problems in everyday life. And plus, if on X-ray, if he's got a good look, nice looking X-ray with no major sign of arthritis, then I will go for an ACL reconstruction. A lot of these people, I do send them to physiotherapy, but by one way or the other, maybe your physiotherapists are not that keen or that competent. So, because I tell you, because I do see some patients on and off. I have seen quite a lot of footballers who had their ACL torn and they are still playing football. But the patient who come to us, majority of the time they come to us because they have problems. If they don't have problems, why should they come to us?
Just a final thing. I'm a part of many social groups there in the Facebook. I used to hear about this thing that I have ACL disease. So that was my point, that whether every ACL disease should be treated or not. But thanks very much, sir. It's my stage.
Right. I
Last
think
comment.
very sorry. Just a comment to add on. I totally agree with the panelist because I being dealing with the specific group of people who are very active and have torn their ACLs, and I tell you, many of those ACL deficient knees are performing much better than the ACL reconstructed knees. That makes one wonder that are we doing our ACL reconstructions properly, or do the patient need the ACL reconstruction to begin with? Because most of them are active, most of them are engaged in high demand activities, and still they can perform better. But having said that, that does not mean that one should not do the ACL reconstructions, because ACL, we know that once damaged, it is not the only structure which gets damaged. There is much extra which has happened to that knee after it reached, the force reached to the ACL and damaged the ACL ultimately. So one must know that what has happened to the knee, starting from outside structures to all the way inside, and all those structures inside. The problem is that most of these patients are presenting late to the clinics, to the right place. And by the time they have reached to the person, already much of the damage has additionally happened to that knee because of the instability which is there. And that at point one makes wonder that whether I should now attempt ACL reconstruction in this knee at all or not, or leave it as such.
See, your topic of research is very good. It's the paradigm shift, and there is a new paradigm shift. You know, we are now going back to the basics, and there is more talk about a repair rather than a reconstruction, because what we are saying, or what I'm hearing from around the world, is that one size fit all doesn't really work when we talk about ACLRs. So with the tunnel drilling, tunnel malpositioning, so ACLR is not, though is still a gold standard, but it's still not the perfect solution. So we are still looking for the perfect solution for ACL injuries and instability sort of problems. So yeah, it's a very interesting topic, and thank you very much. You've done well.
Thank you very much.
Thank you, Dr. Faiz. Professor Mark is online. I think he is available for questions after his two presentations. And the two talks will be on overview on management of treatment for patellar instability. The first talk and the second will be after this. And you can note the problems and question. He is available. You can question him. Thank you.
Annual International Pak Orthocon meeting. My name is Mark Tompkins, and I will be presenting on management and treatment for patellofemoral instability. I want to express my gratitude to Professor Makhdoom, Osama bin Said, and the entire organizing committee, as I am very grateful to be part of this meeting. I apologize that I'm not able to be present in person, but thank you for allowing me to. I want to cover a number of different things today. In particular, I'm just going to go ahead to the overview. The biomechanics of the patellofemoral joint are critical to understand and consider when thinking about intervention, in particular surgical intervention. And so it's important to understand all the different bony anatomy risk factors, and then to be thinking about how we rebalance the patella from medial to lateral. So biomechanically, it's important to remember that the patellofemoral joint is very complex, and one of the roles of the patellofemoral joint is to increase the moment arm of the quadriceps or extensor mechanism. The cartilage is 5 millimeters plus thick because the forces seen by the patellofemoral joint are significant, 3 to 5 times body weight. It's important to remember that the patellofemoral joint has motion in multiple different directions, medial to lateral translation, but there is also rotation in the axial plane and coronal plane, and then we also have flexion and extension in the sagittal plane. There are multiple patellar stabilizers, both static and dynamic stabilizers, and we must consider all of them when we are thinking about how best to help to stabilize the patella. Before we get to anatomic structural risk factors, it's important to remember that there are significant problems in many of these patients with neuromuscular function. One of the things that we see is patients having problems with dynamic knee valgus, and then also issues with overall central control, especially of the pelvis and hips. Oftentimes patients will have internal rotation of the femur and difficulty keeping their pelvis level. In contrast, in the coronal plane here, what we want to see is the knees over the toes with the hips level. Sagittal plane, it's not uncommon that there's poor engagement of the thigh muscles, and therefore you get excessive anterior knee excursion. You can see the difference from left to right in terms of the tone of the musculature. In particular, the thigh muscles, we have good firing on the right, and therefore less stress on the patellofemoral joint and less risk of the of the patella dislocation. It's also important to know other modalities, in particular taping. Medial to lateral taping, otherwise known as McConnell taping, is a mainstay of treatment that we use both before and after any potential surgeries. One of the things I enjoy about patellofemoral management is that it's complex, and it's complex because there are so many different places where you can have problems that lead to patellofemoral instability. You can see an illustration of those here. And subsequently, we also have many different surgical treatment options to address those areas of structural abnormality. So I'll go through 5 main risk factors that I think about in every patient that I see. The first is patella alta, and as you all know, this is a problem with engagement, particularly in the first 60 degrees of flexion, where the patella does not adequately overlap the trochlea, increasing the chance of it coming out of place because it is not adequately engaged. Here's an illustration of a normal knee. You can see good overlap between the patella and trochlea throughout. And in an abnormal knee, it requires more flexion before we actually have adequate engagement of the patella, and that patella will be stabilized. During those degrees of flexion before the engagement happens, there is an increased risk of the patella coming out of place. I typically utilize the Caton de Champ and the Insol-Savati ratio in terms of measuring this, and when we identify patients with alta, these are options that we have for treatment. The mainstay for me is the tibial tubercle distalization. I think patellar tendon shortening is something that can be utilized, and most commonly in skeletally immature patients, but I prefer to do the distalization where we're using bony healing as opposed to soft tissue healing. The next risk factor, and these are the 2 most common risk factors, is trochlear dysplasia, which you know is a poorly formed groove. The problem with that is it causes abnormal engagement or no engagement of the patella during early motion in a similar pattern to what we see in patella alta, such that the patella is not guided into place and can easily go to the wrong spot. On x-rays, we will typically look for the crossing sign, and on slice imaging, the measurement that I most commonly utilize is the sulcus angle, although there are many measurements. The reason to manage trochleoplasty, I do trochleoplasty differently than this at this point. The goal is still to create somewhat of a groove, but in particular to get any kind of prominence or supratrochlear spur out of the way and allow better engagement of the patella with the trochlea. Extensor mechanism is important. It's not uncommon to have an increased extensor mechanism. What that means is basically that the extensor mechanism is laterally aligned relative to the groove. This can be for many different reasons. One of the things that we measure is the TTTG, or the tibial tubercle trochlear groove distance, and when we see that that is elevated, then we are thinking about whether we should do something to move the tubercle. In this case, typically I utilize an anteromedialization osteotomy of the tibial tubercle. I think it's important to recognize valgus. That sometimes is because of abnormality of the weight bearing is too far lateral, which again puts the extensor mechanism laterally oriented relative to the groove, and so you can osteotomize the femur to change that center point and overlap the patella more efficiently with the trochlear groove. It's also important to consider valgus. In this situation, the center of weight bearing is too far lateral, which again puts the extensor mechanism laterally oriented relative to the groove. And so you can osteotomize the femur to change that center point and overlap the patella. And the final bony issue is axial plane issues in the femur, anteversion, and in the tibia. Typically in the U.S. we are referring to that as torsion. The femur is typically internally rotated, the tibia is typically externally rotated, and again, this causes poor engagement or overlap of the patella with the trochlea. Treatment for this, actually let me cover measurement first, is typically done with a CT scan where we get hip, knee, and ankle CT images to look for abnormal amounts of axial plane abnormality, and this is treated with osteotomy of a derotation nature, and that can be done at multiple different points, proximal, mid-shaft, or distal. I utilize all. It depends on the patient. In the example here, I'm showing how we utilize mid-shaft osteotomy. When we think about medial to lateral translation, it's important to consider patellar tilt. In particular, this is really a function of what's happening in the lateral retinaculum. And if the lateral retinaculum is too tight, then it causes the patella to not be oriented in an appropriate position, and that increases the risk for poor traction. What I prefer to do to treat this is to utilize a lateral retinacular lengthening as illustrated here. I do this in roughly 90% of my patellofemoral instability surgeries. As you all know, the mainstay of treatment for patellofemoral instability is the MPFL, or medial patellofemoral ligament reconstruction, which is done for MPFL insufficiency. The key concept here is that an insufficient MPFL does not adequately restrain the patella on the medial side. Our goal with MPFL reconstruction is not to pull the patella where we want it, it's simply to help hold the patella where we want it, so to guide it rather than to pull it. You can see images here demonstrating on x-ray where we want the attachment on the patella. I also typically utilize a limb that goes into the quad, since we know that the medial sided attachments from the femur attach both to the patella on the proximal 1/3 to 1/2, but also attach on the distal quad. And then important to remember Shuttle's point on the femur. So again, I think a summary of the surgical goals, it's important to consider any relevant anatomic factor. In some patients, they have multiple anatomic factors that are contributing to the patellofemoral instability. It is not possible to treat all of those. So it's important to identify which ones we think are most problematic, and also which are most likely to be the highest yield, and address those. Sometimes that means more than one, sometimes it means just one anatomic risk factor, and then rebalancing the patella with an MPFL on the one side and a lateral retinacular lengthening on the other side in order to help stabilize the patella side to side. Again, the goal is to help guide the patella into the groove, not to pull it into place. I think it's also critical, as we talked about at the beginning, that it's important to remember the non-surgical treatments for this, and it's of the utmost importance to be doing adequate physical therapy following surgery. In addition, this is a long recovery, and so it requires that patients, and in many cases families, are involved with good understanding and commitment so that they can follow through the entire rehab process. Thank you again very much for the opportunity to present and be part of this meeting. Thank you very much for the opportunity to present at the 36th Annual International Pak Orthocon meeting. My name is Mark Tompkins from the University of Minnesota in Minnesota, United States, and I am very grateful to be part of this meeting, so I want to express my gratitude to Professor Maktoum, Usama bin Saeed, and the entire organizing committee. Thank you very much for including me as part of this. In this talk, I will be speaking on how I manage focal cartilage defects at my institution. I'm excited to share the ways in which I'm trying to manage. Key part of that is the biology. We'll speak briefly about non-operative management and then get into different surgical treatment options. For biology, as we know, we're discussing hyaline cartilage here, which the main role is to minimize friction and distribute force. It is avascular and aneural, which obviously has a significant impact on treatment and healing and how we manage that. Important to remember that the nutrients are derived from synovial fluid and the bone marrow. I think in particular from a biology standpoint and from a surgical standpoint, when we think about the biology, it's important to be considering the composition. So in particular the chondrocytes, but also the extracellular matrix, of which most is water, but important components of collagen, specifically type 2, proteoglycans, and non-collagenous proteins. In particular, as regarding the chondrocytes and collagen, the orientation and distribution of these components is critical. So we all remember the layers, the superficial layer, which is key in resisting shear forces. Because of that, the chondrocytes and collagen are oriented parallel with the surface. There's a transitional layer where the cells are more spherical, and then there's a deep layer which is meant to resist compression, and in that layer the chondrocytes and collagen are perpendicular to the surface. In addition, there is also the calcified cartilage layer. So these are all things that we're considering when we're thinking about how we might rebuild cartilage in an area of a defect. Before we get to surgery, though, it's important to remember there are options for trying to manage these conditions non-surgically. In particular, physical therapy is critical. Sometimes it's not so clear whether the cartilage is the problem or whether there are other things that are causing pain in the knee, and physical therapy is critical to make sure that the mechanics of that person's knee are as good as possible. In certain cases, especially where there's malalignment, I utilize an unloader brace, which can be helpful in determining where the symptoms are or if it is related to the cartilage. In some cases, we utilize injections, although this is rare in focal defects, more common in degenerative changes. Certainly can be managed with typical management such as anti-inflammatories and compression. Some indication of improvement with supplements like glucosamine and chondroitin, more so again in the setting of degenerative change. In all of these situations, it's important to remember that this is symptomatic relief. The defect is still there, and so if we think that the defect is the source of the pain, then we do start thinking about surgical management. The original mainstay of treatment for surgical management is microfracture. This can be done two different ways, using an awl or with a drill. Both have potential problems. In the case of the awl, there is subchondral fracture, and then this can be a problem in terms of adequately supporting the cartilage, or even potentially with subsequent procedures if there's other procedures that we need to do. The drill, in a similar fashion, can cause problems by creating too much heat and causing necrosis of some of the bone, in particular the osteocytes and other cells. So what this does is it creates pluripotent cells, but the problem is that it creates fibrocartilage. And here you can see the problem with fibrocartilage is that it's both type 1 and type 2 collagen, and it's just simply not as durable, and it doesn't create cells and collagen oriented in the same way as hyaline cartilage, which therefore impacts the function of that cartilage, again, in the durability. The most ideal patients are going to be patients with smaller lesions. It's critical that they have stable borders. The picture on the right there shows a bone defect. That is not a great patient for microfracture. Ideally, they have the subchondral bone intact. This is typically done on femoral condyles and younger patients with normal alignment. A procedure that I really like to do, although it's limited because of the size, is an osteochondral autograft transfer. So taking bone and cartilage from somewhere else in the patient's knee and placing it into the defect. Ideally, it's just 1 or 2 plugs, because otherwise we really start getting into areas that are useful in other parts of the joint. So in particular, I like to harvest from the lateral trochlea, but the distalmost aspect, which is just proximal to the sulcus terminalis, where we think that there's not, in most patients, a significant amount of pressure, and therefore we can remove cartilage and bone from that area, but you still have good cartilage and good thickness of the cartilage in that area. So the main limitation here is that we just can't take it from a very sizable area. So if the defect becomes large, then they are not an ideal candidate. So the most ideal candidates are those patients who have focal lesions of a moderate size and normal alignment, and then on the femur. I liberally use this option, which is osteochondral allografts. Some concern for disease transmission, although these allografts are handled very well in very careful conditions, and fortunately we have never seen any type of disease transmission. Another concern is the viability of the cells, so they're also handled in a way to maintain the viability of the cells as much as possible. You can see in the text there what studies are showing at this point in terms of cell viability with the current preparation for osteochondral allograft. These can be used in a number of different scenarios. It doesn't have to be large defects, but in particular it's useful in larger defects and defects that involve both bone and cartilage, most commonly in some type of traumatic situation or OCD, occasionally in post-medication related, so for example chemo in patients being treated with malignancy and who end up with osteonecrosis. This can also be used for salvage in uncontained lesions, although most ideally done in contained lesions. Cell-based treatments, of which there are several, it's important to keep in mind that cell-based treatments can be utilized in many situations, but in particular when subchondral bone is maintained. In the case of matrix-induced autologous chondrocyte implantation, or MACI, this is a two-stage surgery where cartilage biopsy is done in the first stage. The cells are sent to a lab and multiplied, and then they are seeded onto a membrane, which is then implanted in the second surgery. This creates hyaline-like cartilage where we have living chondrocytes in some structure, but it is not the same composition as what you would get with autograft or allograft. Again, thinking about the positioning, the density, and orientation of the cells as well as the collagen. So this does not completely recapitulate those aspects. The most ideal patients are patients with larger lesions and a focal defect. It can be done with more than one defect, but ideally one. And again, as I mentioned before, no bony involvement, and as is a theme here, no problems with alignment. There are, before I go on to the next one, I would mention that in the U.S. we are currently testing for a procedure similar to MACI, which is called NovaCart. Same idea that it's a two-stage procedure. The main difference is that the membrane, which is utilized, is a different texture and durometer. I've been fortunate to be part of a study looking at that. We have just reached the end of enrollment, and we will be following these patients for at least 2 more years. This is a procedure that is done with some regularity in Europe, and there have been good results reported. So hopefully it's something that we'll be able to do here at my institutions before too long, outside of a study. The next cell-based treatment is particulated juvenile allograft. This is a single-stage procedure, and this is donor tissue that is minced, so it's handled minimally, meaning it's just cut up, but otherwise not processed other than the usual evaluation for disease transmission. This then, the small pieces of cartilage are put into the lesion using fibrin glue. Again, this creates a hyaline-like cartilage, and the most ideal patients are similar patients to the MACI patients, where it's a larger lesion with a focal defect and no bony involvement and no alignment problem. There are emerging technologies that are available, some of which I have used, and so I'll go through those. These are listed here. The first one being Prochondrix or Cardiform. There are 2 different companies that are currently distributing this. This is essentially allograft cartilage that has been processed to allow for ingrowth from the underlying bone to help hold the cartilage in and seed some cells onto the cartilage as well. There is typically a very thin layer of bone on the back of these grafts that also helps with ingrowth. I think the utilization of these is still being worked out. I have done this on a couple occasions in patients where they just weren't great candidates for other options, but did have intact subchondral bone. Another one is AMIC, or autologous matrix-induced chondrogenesis. The idea being that you create an area for the cartilage to fill in, a little bit similar to microfracture. However, this is done either using a membrane over the top or some type of membrane that the cells from the subchondral bone or from the cancellous portion deep to the subchondral bone can seed onto. So it's kind of advanced past microfracture. I have not yet used this, although I know that there are people using it and have been satisfied with the results. Again, though, I think we go back to what kind of structure is this creating. It is likely that this is at best creating hyaline-like cartilage, but it may also just be creating fibrocartilage. Again, therefore, we would not expect this to perhaps have it as great of durability as some of the other options. That is why I have not used this at this point. Another idea is to use a collagen membrane and bone marrow aspirate. So again, we're trying to seed a membrane, but the cells are coming from the bone marrow in this case, and then that gets applied into the defect. And then there are also emerging technologies with PRP and stem cells being injected into the knee with the hope that it helps to fill the defect. I think these are very early studies, and we do not know the results yet. Another option in the US, this is called lipogems, where fat is harvested and the stem cells from the fat are processed off. This is all done sterilely in the operating room or in the office, and then those stem cells are introduced into the knee. I think the results of this so far are mixed. I think there are some studies indicating that there is some value, and there are other studies indicating that this is not yet fully worked out. I think it's very important when we're thinking about cartilage, regardless of the procedures, and again, my mainstays are going to be an osteochondral autograft transfer if it's small enough, and osteochondral allograft if it is larger. If the subchondral bone is intact, then I do consider either MACI and would consider Novacart if it's available in the future, as well as the particulated juvenile allograft. Currently, unfortunately, that is not covered by insurance, so that is not something I'm doing with regularity currently, but I have in the past. Regardless of which of those procedures you're using to try to rebuild the cartilage defect, it's critical to think about alignment. So if there is alignment issues, then I think it's important to consider changing those alignment issues, typically through an unloading osteotomy, such that weight is more evenly distributed, specifically forces are more evenly distributed, which can then augment the cartilage procedures. In addition to that, it may also help with some of the forces that the cartilage is seeing in terms of shear and compression. It's also important to remember that we can't treat every cartilage defect. Some of them are too non-focal or too advanced in terms of degenerative change, and then in that case we either have to leave it and think about some of the non-surgical options. Once we have run out of non-surgical options, or the efficacy is no longer present for the non-surgical options, then we're sending these patients to our colleagues who are doing total joint replacement surgeries. Thank you very much again for the opportunity to present. I'm grateful to be part of the conference.
Osama,
Any question? I think Mark is online.
he's online.
Any question, please?
Hello. So anyone has any questions?
Regarding cartilage injuries and patellofemoral problems. So if there is no question, I will move to the next talk by Professor Syed Dilbagh Ali Shah.
Is he there online? You can thank him for his presentations. There is no question.
Dr.
Thank you
Sami.
very much, Mark. It was a great pleasure to have you. Hello. Thank you, Mark, for being with us today. It was a great pleasure to have you here. It would have been greater if you were there physically. Hopefully, at some stage, we would have it. It was an interesting topic, and we enjoyed it thoroughly. I don't know about the time, but I wish you a good day there. And it was a pleasure to have you today with us. Thank you.
I don't know if you, hi Mark, can you hear us?
I can hear you. Can you hear me?
Yes, we can.
Okay, perfect.
It's still dark in the background, so I suppose it's too early in the morning.
It's okay. No problem. I'm grateful to be a part.
No, thank you very much for waking up early for us, and it was a real pleasure to have you here. Your both talks were very informative. The crowd here thoroughly enjoyed it. So anyone has any questions, just briefly, while Mark is here with us? So for the MPFL, patellofemoral instability, so would you do MPFL, prefer to do it alone, or would you combine it with some other procedures? Now, this is kind of a tricky one, I suppose. So let's hear from you.
Yeah, excellent question. I think that's
Right. We still have a problem with the connection. Just give us a second. Are we? Can you hear us? Okay, we can't hear you, so we're just trying to. Guys, can we? Hello? Hello?
Yeah, I can hear you.
Yeah, I can hear you now, yeah, so please go on.
Okay, perfect. I was saying that it's a fantastic question. I'm fortunate to be part of what's called the Jupiter Group, and we just received some funding to initiate a new study. We've already done one prospective study with about 2,000 patients, but now we're initiating a new study where we are only including patients who are undergoing isolated MPFL reconstruction. What I would say is I think that this is a difficult question. I mean, I think in many cases, an isolated MPFL reconstruction will make patients feel better, but I don't think that it most of the time adequately addresses what we need it to address. And I think it's important to put in context, I'm a little biased because I am fortunate to have a pretty complex patellofemoral practice. So in that practice, for me, it's rare that I do an isolated MPFL because most of the patients that I'm seeing are referred because they have pretty complex anatomy problems. And I think in those patients, if we only do an isolated MPFL, we might make them feel more stable, but we don't adequately treat the underlying problem. And so I think that in the end, the most important thing is to do enough surgery that we try to treat the problem. I think in some cases, we can't treat everything. It's just too much surgery, too complex. But I think most of the time, if a patient has underlying bony anatomy problems, we should at least address one or more of those bony anatomy problems in addition to doing the isolated MPFL. So I think, I don't know because we're studying it, but I think in the end, we'll find that MPFL alone oftentimes will make the patients feel more stable, but that if we have adequate ways of assessing outcomes, that the outcomes will be somewhat better if we also address one or more of the bony anatomy problems.
So far, the most common associated procedure you would do with your with the MPFL bony procedure would be?
Distalization of the tibial tubercle, because the two things that we see most commonly associated with patellofemoral instability are patella alta and trochlear dysplasia. That's been borne out in a number of different studies, including studies that we have done. Many times that trochlear dysplasia, for me, does not necessitate a trochleoplasty. Most of the time, it can be managed, the combination of the two or the isolated patella alta can be managed with the distalization. I certainly do trochleoplasties when I feel it's necessary, but it's much more common to do tibial tubercle distalizations than the trochleoplasties.
Thank you very much. Much appreciated. And thank you for waking up so early for us. Thank you. There's another question, please.
Thank you very much. It was a very interesting topics both you covered. I have a little my prehension. If we distalize the tibial tubercle and we are increasing certainly a lever arm, how much time we are putting the patella under loads, how much time it is increased? Is there any biomechanical study regarding this one?
Yeah, that's an excellent question. Certainly, we're changing the biomechanical forces in the patellofemoral joint. I think in some of these patients, that's actually, hopefully most of the patients, that's additive. In other words, we're getting better engagement of the patella with the trochlea, and so hopefully those forces are being distributed in a more diffuse way. So it's not so much of an issue on a small surface area. Your question about whether that's been well studied, I don't think, unfortunately, that it has been well studied, but I think there are certainly good studies looking at anteromedialization osteotomy and what that does to the loading. And we know that, you know, generally distal and lateral lesions of cartilage anyway are unloaded. So I think a similar idea would apply when distalizing. If we don't have very good overlap between the cartilage of the patella and the trochlea, and then we improve the overlap again, we should be distributing those forces in a more ideal way in terms of the forces that each small portion of the structure are seeing.
Yeah, thank you very much. Thank you. Again, thank you very much from Pakistan, and it was nice having you here. Thank you again.
Thank you very much. Thanks a lot for letting me join. I appreciate it.
Thank you. I think we are short of time, and I will move to the next topic by Professor Dilbagh Ali Shah, and the topic is posterolateral corner injuries, importance and its management. Thank you.
Okay, Bismillahirrahmanirrahim. I'm Dr. C. Dilbagh, working as a consultant orthopedic surgeon at Heber Teaching Hospital, Peshawar. Slide movement कहाँ से करते हैं? Okay, so topic for discussion on my behalf is the posterolateral corner injury, what is its importance and how to manage such problem. Now, first of all, what is the term stand for posterolateral corner injury? So basically, this is a complex, which is made up of number of structure which stabilizes knee from the posterolateral aspect. The structure which make it comprises of the fibular collateral ligament, second one is the popliteus tendon, and third one is the popliteofibular ligament. In some of the articles, they have combined the lateral gastrocnemius tendon also in the same complex. But majority of the the literature, the three structures which already have mentioned, they constitute the posterolateral corner of the knee joint. Thank you. Now coming to the importance of the posterolateral corner injury. In the literature, there are a lot of studies which show the significance of this important stabilizer of the knee. One of the studies has suggested that there is significant increase in the loads when you construct ACL in the absence of PLC. You can see from this graph that when the knee is in 30-degree varus, and then there is significant increases of the load on the ACLs, which indirectly gives the reflection that if a surgeon is going to miss the posterolateral corner injury and is going to reconstruct ACL, so there is very high chance that this ACL will fail. Another study suggests that if you ignore posterolateral coronary injury and you are going to do the ACL reconstruction, by the time you are going to tensioning the graft, I mean when you are tightening the tibial end of the graft, there is a good chance that you are going to externally rotate the tibia. Again, it will end up with the, I mean, abnormal mechanical loading on the ACL, and it's going to fail again. So besides this, there are a lot of other studies which are going to, I mean, emphasize the importance of not to ignore the posterolateral coronary injury whenever you are going to do arthroscopic surgery, a particular ligament reconstruction of either ACL or PCL. So you have to, I mean, take care of the PLC injury very much. Now a brief overview of how you are going to manage the posterolateral coronary injury. Again, in the literature, a lot of, I mean, operative procedures and lot of the, I mean, operative techniques have been described. But in this article, I mean, they have good review of number of the, I mean, studies, and they emphasize the importance that reconstruction of the three main primary stabilizers, which are the fibular collateral ligament, popliteus tendon, and the popliteal fibular ligament, is the one which is gold standard, which gives much more stability. So basically, the different techniques are different from reconstruction point of view of the posterolateral coronary injury are whether you are going to reconstruct PLC based on both the tibia and fibula, or you are going to use just only fibula for stabilization. So from this, I mean, the Laprade, the technique which reconstruct all the three is, I mean, considered much better than the others. Now, for management point of view, we must know the classification, in other words, the severity of the posterolateral coronary injury. So the commonly used in the literature is the one which is called Houston, and they classify basically into three grades. In the grade 1, basically there is varus of 0 to 5 millimeter or 0 to 5 degrees rotation of the rotational instability is there. And they suggest that this I mean, varus which opens 0 to 5 doesn't need any reconstruction of the posterolateral coronary injury. The other one is the one where the 5 to 10 millimeter opening of the knee joint on the lateral aspect. They advise, I mean, that is called as the moderate ligament disruption. And if it is beyond this, then they labeled it severe. Now, based on this classification system, there's the algorithm which suggests that what to do in which case of the severity. So as we mentioned already, if it is grade 1, so non-operative measures are enough in form of the physiotherapy, analgesia, and rehabilitation. If it is grade 2, then if there is isolated injury and patient is not, I mean, not very much competitive athlete, so you can again go for the physiotherapy and non-operative measures. But if there is any avulsion injury, then and patient is also, I mean, demanding in form of the, I mean, the repetitive sportman, then primary repair is recommended. Now, the problem arises when there is particularly grade 3 injury. So again, grade 3, you have to take the detailed history of the patient, and then you have to, I mean, exactly mention that whether it is acute or it's chronic. Basically, 3 weeks is considered the landmark. If it is less than 3 weeks, considered chronic. If it is beyond 3 weeks, then it's considered, I mean, beyond 3 weeks, then it's considered chronic. If it is less than 3 weeks, that's acute. Acute goes, I mean, again, in the same path as for the grade 1. But if it's chronic, again, then chronic, you have to do the scanogram of the patient to make sure about the alignment of the bone, of both of the lower limb, basically, tibia and femur. If there is malaligned, so high tibial osteotomy would be the answer to this posterolateral insufficiency. But if there is no malalignment, then you can have again assess whether there is rotational deformity or whether there is only varus issue or whether it is combined. So accordingly, you have to do the reconstruction of the ligaments. Now, just, I mean, we have alhamdulillah, a number of cases, but just I'm presenting case here to emphasize the importance of the PLC injury. We received a 32-year-old gentleman having road traffic accident. On the assessment, he had isolated knee injury, which was neurovascularly intact. It was closed injury, and patient was giving the history of instability. And he was particularly having problem with the stairs, and he was complaining of giving way of the knee joint. There was various thrust. Sorry, this video is not playing, but we assessed it. It was all unstable in not only in 30-degree, but also in full extension. Among the special tests, Lachman was positive and the dial test was positive. So you can see that on the affected side there was more stenotation than the normal side. A stress radiograph again indicated that there was more opening on the lateral aspect of the knee joint. MRI showed there was fluid around the popliteus tendon. So all these were pointing toward the posterolateral injury. So this patient had combined ACL and PLC injury. So option of treatment with us were either to do the ACL reconstruction first or to go for the PLC reconstruction first or combine both the procedure in same setting. So keeping in mind the importance of PLC injury, we did PLC reconstruction first, and following that 6 weeks later we did ACL reconstruction. So how we did the PLC reconstruction, because the talk is on PLC reconstruction, so we harvest normally the semitendinosus graft. We prepare the graft, and this is the lateral approach. This is basically open procedure because this is the extra-articular structure. So you can see that common peroneal nerve identified and secured. Then we make the tunnel for the femoral attachment and for the tibia and fibular attachment. And then the figure of 8 configuration is restored. So basically the long tendon in the middle, we make a loop. The loop is fixed on the femur side. One limb is passing in the tibia from anterior to posterior, from posterior to anterior, and the other limb is passing from fibula anterior to posterior, and the fibular end which has gone posteriorly again through the tibial tunnel is pulled anteriorly. And the x-rays, the 2 screws which are shown on the APN lateral view, they are the one which are for the PLC. The remaining 2 actually they are the one with which we have stabilized the ACL. Again, I want to mention here that this was actually performed in 2018 when we didn't have access to the endo-button facility available. So nowadays we are using endo-buttons and the anchors for most of the cases. So if I am able to play this video. But ये video कैसे play होगी? So I mean you can see the scar is the one from where we harvest the tendon. The arthroscopic scars are there because this is a couple of months later, and this was the scar for the PLC. So alhamdulillah, this was quite stable after a couple of months. So the message which I want to give from this desk is that never ignore the posterolateral coronary injury when you are coming across the ACL or PCL injury. And other thing is to keep in mind is this is the injury which most of the time doesn't heal, particularly if it is grade 3 injury. So, and reconstruction of the PLC is preferably has to be done before the reconstruction of either of the intra-articular ligaments. Thank you so much. If any question, please.
It's an interesting topic. Any question?
Thank you.
Thank you.
Thank you. Dr. Muhammad Muzammil, if he's present. Dr. Muhammad Muzammil. Dr. Zain Mahmood. Okay. So the last will be free paper presentation by Dr. Sabir Khan Khatak, and is on arthroscopic ACL reconstruction using adjustable loop endo button on femoral side and bioabsorbable screw on tibial side. Dr. Sabir Khatak.
Bismillahirrahmanirrahim. My talk about functional outcome of arthroscopic anterior cruciate ligament reconstruction using hamstring autograft with fixation using endo button at the femoral end and bioabsorbable screw at the tibial interface. My name is Dr. Sabir Khan. I'm a resident orthopedic surgeon at Gurki Trust Teaching Hospital. So this is a picture, our department picture. So introduction. The anterior cruciate ligament tear are the most common knee injury in adult population, with the rise in participation in sports mostly. In Pakistan, most of the patients are unaware of the nature of the injury and rely mostly on the conservative management without consulting an orthopedic surgeon, leading to chronic pain, instability, and early onset osteoarthritis. The most commonly used graft are BTB or hamstring autograft. The graft fixation method include interface screw, aperture fixation, endo button, suspensory fixation method, and transcondylar rigid fixations. Arthroscopic ACL reconstruction is the standard technique nowadays to treat ACL tears. What is the objective of our study is to analyze the results of the arthroscopic ACL reconstruction in the femoral, using the femoral tunnel with quadricep hamstring autograft, implying an endo button at the femoral end and the bioabsorber interface screw at the tibial end. What are the material method? We use a prospective observational study, and it was done in Gurki Trust Teaching Hospital. The duration was 1 year with the minimum 6 months follow-up after surgery, last surgery. So the sample size was 40. The inclusion criteria was both genders. We included that has undergone ACL reconstruction, and it was more than 18 years and willing to participate. The exclusion criteria was concurrent fractures, associated medial or lateral collateral ligament injury, or posterior cruciate ligament injury, or BLC ligament. The recurrent ACL injury not willing to participate was excluded. Sampling technique, we use a simple consecutive random sampling technique. Methodology, the demographic information like name, age, and sex was recorded. Proper history and clinical examination were carried. Lackman test, interior drawer test, and pie shift test was performed. Graded as 0, negative, +1, +2, and +3 positive. Whereas an valgus test was done, McMurray test was done, and posterior drawer and reverse pie shift was done. MRI of the knee was performed. Methodology, the demographic information like name, age, sex, and address were recorded. Proper history and clinical examination were performed. So on which scale we assess the patient? We assess on IKDC scoring system. The minimum was 0 and the maximum was 100. The functional outcome of the patient was assessed through preoperative and postoperative IKDC scoring system as mean plus minus standard deviation. Data was analyzed through SPSS, and the p-value that is 0.05 was considered as statistically significant. Operative technique. So anteromedial and anterolateral portals were used. The standard technique of the ACL was used. The oblique incision was made for the graft harvesting, 3 centimeter anteromedially on the proximal tibia and distal to the joint line and 3 centimeter medial to the tibial tuberosity for graft harvesting. Quadriceps tendon of at least 70 centimeter was harvested. Ithicon sutures were used for preparation of the proximal and distal ends of the graft. Femoral tunnel was prepared using anteromedial portal with knee in maximum flexion, that is 120 degree. Tibial tunnel was prepared with tibial guide. The graft was prepared with appropriate size and in the button loop. And using when the Ithicon suture is passed from the tibial tunnel to the femoral tunnel, by gently pulling the strings, the endo button was twisted against the lateral cortex. Approximate size bioabsorber screw interface screw was used to fix the graft at the tibial end in the extension of the knee. So this was the technique we used in the MRI, some MRI scans and the post-operative pictures. So the post-operative care, we used IV antibiotic for 3 days, knee immobilizer, and the physiotherapy was started on the next day of the surgery to check range of motion. And range of motion increased gradually from after 1 month to full weight bearing, and more than 90 degree of flexion was started. So the result was there was 38% was male and 2 patient was female, so 95% was male. So the knee side involved was 30 on the right side and the left was 10. Moderate of injury, RTA was in 25%, 25 patient, 62.5%. Sports was in 32%, and the miscellaneous was 5%. So most of the cases, 75% cases present with a feeling of giving way of the knee during routine work or walking with pain with or without locking, while 25% cases had the feeling of giving way was only during sports or heavy labor, using with pain or without locking. So the IKDC scoring, the results is the 7.5% had normal, 7.5% had near normal, 62.5% was near abnormal, and 22.5% was severely abnormal in the preoperative. So the postoperative IKDC scoring was compared, and it was 81. The preoperative was 41 in our population, and the postoperative was 81 plus minus 12. So the p-value was highly significant, that 0.01, which is statistically significant. So postoperatively, after subjective assessment and patient satisfaction, 50% of the cases the result was very good after ACL reconstruction. About 35% cases reported well, and 10% cases results were satisfactory. The remaining 5% was having bad results, and they were not satisfied from the results. So at present, 30% patient has returned to the intense sport activity. 55% patient have medium sports activity, while 15% patient have small sport activity. Discussion. All the patient in our study underwent reconstruction with a hamstring graft by employing an endo button at the Kohli's. So we compared our studies. Kohli's et al. Concluded from their study on ACL reconstruction, which they use quadriceps folded semitendinosus graft, that this method provides excellent clinical results and the patient attains almost pre-injury activities. The endo button used is not directly fixed in the graft. There is a nylon threaded present between the endo button and the graft. This suspensory fixation is associated with increased interior knee joint laxity. In this study, we found 5 patients had grade 1 laxity after 6 months and grade 2 laxity in 2 patients after at the end of final follow-up. Regarding post-operative IKDC scoring, our patient had, our study had 81 score, which is very close to the 91 score of Sebold et al. Using the same technique, and 82 score of Glitti et al. Using double standard hamstring autograft. 85% patient case of ACL tear reported that their knee area are normal or near normal, group 1 A or B after reconstruction, which is in accordance with 95% cases reported by Juma et al. At 5 years follow-up using earlier either BPTB graft or hamstring, and 95% of Sebold et al. Using endo button. So what was our limitation? There was small sample size of around 40 patients. That was our limitation. Further comparative study can be used with a large sample size and longer follow-up on this technique. Conclusion: ACL reconstruction using hamstring autograft with endo button on the femoral end and biabsorber screw at the tibial end is a superior technique than other, as 95% of the patient are satisfied with the result, and hence it should be the first choice technique for ECL reconstruction. Thank you.
Yeah.
So the post-operative, GG. It's actually subjective assessment. We interview the patient after ACL reconstruction after every 2 months, and after on every follow-up we interview the patient regarding the satisfaction of the procedure. So many patients were satisfied at the end of the follow-up after 6 months, and only 10%, 4 patient was so post-operatively, 14 patient cases report well, and 4% cases and 10% cases that were satisfactory. The remaining 5% cases were having bad results and they were not satisfied.
What was the reason for that bad results?
So they were not satisfied. It was not on the behalf of the surgery or due to the technique difficulty, but the patient usually complain of the pain and for which initially the surgery was performed.
There must be some reason for the pain.
So the reason for which they underwent surgery, the pain was not relieved and they was not satisfied with the procedure.
Your preferred graft was the SAMI-T.
Yeah.
SAMI-T. When you harvest SAMI-T, what percentage of the medial chakra is suffered, and how much external rotation is increased when the loading of knee begins? When you take one of the, what I am talking about, there are 2 chakrins of the knee, one on the medial side and on the lateral side, the medial hamstring, the lateral hamstring.
Yes.
If you take one of the medial hamstrings,
Yes.
are you going
Hi, sir. I'm
to give any disbalance to the knee?
Sorry, I'm going to take on this. A shoulder surgeon is jumping into the knee. I think the resident, do you have any faculty member, senior faculty member with you here in the audience who could take on the question?
Just a 6 months follow-up, so you don't expect.
So we didn't.
Just the panel's comments.
Okay.
It's just a 6-month follow-up, so you can't expect wonders in 6 months, because the least we expect from ACL to work perfectly is around about 1 year.
Yes.
ये पाकिस्तान का बटन है but it's just a 6 months follow-up, so you can't expect wonders in 6 months. I think personally I feel the minimum you can expect good results from the ACL is around about 1 year clinical results.
The short-term follow-up is not.
Yeah.
That's good.
Excuse me, was any case of infection in your study?
At the end of the study, at the 6 months, there was no infection in any cases, so we didn't mention that.
Just another question. When I used to do knees, did it ever happen to you that you blow out the tunnel, far tunnel, and the endo button is no more working? Did you have any option at hand what to do with that situation? Again, a very technical question. I have the answer. Just want to know that you have that extendo button available with you, or you don't have it. Probably the other knee surgeon, they could comment on that.
No.
Do we have, like, at times you're just preparing the tunnel for the endo button and you're just going to drill it?
Drill the
We have
femoral.
done so many mistakes that we have got a cure for everything.
Well, yeah, they have, the Arthrex have that extendo button,
We don't have
which
that
is
system.
kind of bigger than the endo button.
But but there are other techniques as well. What I do, especially in revision cases, is that I use this bigger the tibial button, and I put this underneath the other button and just do it like this. You see, for every mistake we have got an answer.
Dr. Sami, we have
Just
trauma principles for it. just apply a washer, simple washer beneath your butt, and it will work for you. Yes, bigger washer.
It just
We can use it. Dr. Sami's question was if you have a blowout,
If you have a blowout.
we should have an extendo button that is a sort of washer, but we have traditional trauma washer, we can use it. No, just the button will be
Your end of button will be remain the same.
exactly. Washer cannot work for an endo button.
Just a follow-up comment on the earlier made comment and a suggestion probably as well. Interviewing the patients as a form of post-operative assessment is fine. And some of the patient will say definitely we are very good. Some of the patient will say that we are not very happy with. But I think it is always better to use standardized scores which are validated. You can translate them and validate in local language because they are difficult to answer because they are in foreign language. So the best scores which are used are patient-reported outcome measures, PROMs. So it is always better that you have one of PROMs in your center, translated, validated in your center, and then you can use that as an assessment tool to add more value to your studies and present in a very good publishable manner in some very good journal. Otherwise, I mean, you can say that some of the patients were very happy, some of the patients are not very happy, but that does not add much value to it. You're doing a wonderful job and it's a wonderful presentation. And I agree with the panelists because the 6 months follow-up is not probably the enough follow-up.
So I think that should be the end of it. So thank you very much.
Thank you so much.
Well done. And the next session.
Exactly with this,
We're done with this session. Yeah.
it's the end of arthroscopy session 1, and we will start arthroscopy session 2. Dr. Sam.
Thank you very much, Dr. Sanalo. So we'll be proceeding with the next session. I would like to request Dr. Khalid Nehmoocha as panelist to please take your seat. And Dr. Kashif Mehman as a panelist, please take your seat so that we can proceed further. Dr. Syed Dilbagh would like to join me as a moderator. So the first talk we have in this session is ACL reconstruction in adolescents and young adults by Professor Dr. Zahid Askar. Sir, please can you come on stage and proceed? Dr. Zahid Askar. He's here.
Right, so we'll be talking about ACL reconstruction in young and adolescent athletes. And I'll be talking about the introduction, epidemiology, then what in the mechanics of injury and the different methods, and then comparing the different methods and telling you at which age group, which one would be appropriate. Now, especially in the West, with the increasing of children participating in sports, there is increasing frequency of ACL ruptures. And especially between 1920 and 2009, there's been a threefold increase in ACL reconstructions in this age group. Now, this is just showing you so this is this is in the male, and you can actually see sort of the peak, especially in the females, is roughly between the age of maybe about 10 to 20. And in males, sort of it's peaks around about that age group, then plateaus, and then comes down. So this is, majority of the time, this is round about that age group we are talking about. And this is a study from New York State, basically showing from 1990 to 2008, and this is the rate per 100,000 people. And this is it has increased about threefold The amount of ACL reconstruction in this age group has increased about threefold from in 10 years. And generally the female, because of their physique, they tend to injure the ACL 2 to 8 times more than male. Mechanical injury is roughly the same in adults. Examination again is the same standard. The only thing is that sometimes they can be quite difficult to examine, and you have to keep in mind that the children, they have a certain level of ligamentous laxity. Investigations are roughly the same. X-rays are very important, especially in this age group. We have to get patellar skyline result to exclude an injury to the injury to the patella. And then again, we also have to assess the chronological, physiological, and skeletal age of these patients. Now, in dealing with these injuries, the major problem or the major fear which we have is growth disturbances. And the growth disturbances can, if they are localized, then they can cause angular deformities. If they are generalized, then they can cause limb discrepancies. And in some cases, especially the ortho-top techniques, there can certainly be overgrowth as well. And it is basically this fear of growth disturbances which has sort of led us to be careful in treating ACL injuries operatively in these patients. Now, generally if you destroy sort of up to about 7%, so destruction of, if more than 70%, it may cause growth arrest. And if you got a soft tissue tendon which across the physeal bar or the physis, it will not cause any growth arrest unless and until there is some compression. So the treatment always has got two options. Shall we treat it conservatively or shall we treat it operatively? And still the jury is out which is the best way of treating it. Still there are a lot of people who are trying to treat it non-operatively. But there are some who are sort of presently now saying that we should treat them operatively. And the advocates of the non-operative treatment, the thing they are basically quoting is these problems with growth arrest and the problems with the growth. Conservative or the delayed treatment, as we say, is the traditional. It has been the traditional treatment, and basically, and this has been this is basically based on the fact that the children, they generally have got increased healing potential, and because any surgical procedure you do, there is a chance that we can damage the growth plate. And so there's various certificates, Words 2014, Moscow. But if you see here, majority of these patients, you have to sort of restrict. You have to restrict them from playing sports, and have to ask them to be quite careful. There's a meta-analysis done by James. And actually, he's compared the patients who are both treated operatively and non-operatively, and also the patients who were, sorry. And in that, he found out that the patients who were treated non-operatively, in different studies, the rate of residual instability rate from about 20 to 100%, and the rate of sort of the ratio of return to sports in the patients who were treated non-operatively was about 6 to 50%. And the patients who were treated operatively, the return to sports ratio was from 57 to about 100%. And what they also said that if you are going to treat these patients operatively, then it's better to treat them early rather than late. Another paper by Lawrence also said that if you leave this patient for more than 12 weeks, you actually 4 times more chance of having a meniscal injuries and 11 times chances of chondral injuries. Now the different surgical procedures we do for these can broadly divided into 2 types. In the one which we spare the physis, so these are what we call the top techniques or the all epiphyseal tunnels, or we can do hybrid. So on one side we go transphysial
and the other side we go entirely epiphyseal, or we can do the complete transphyseal techniques as is done for adults. For the physeal spraying technique, one of a very good technique is what we call the Orthop technique, or the modified Macintosh technique, which is a Michele Cocourt procedure as well. And basically what they do is they take the tensor fasciolata, make a leave it attached to the tubercle, and then just put it on the top of it, pass it through the joint underneath the meniscus, and stitch it to the front of the knee joint. So this is the way they do it. And this is a short video. इसको on कर दे. So what they do is they first take the tensor fasciolata, make about 18 centimeter of long graft, then put it, and then they go inside the knee joint and just do it on the top, pull it with the fiber wire tape underneath the meniscus. And then what they do is then they stitch it to the, so this is the way how it's done, right? And then they will stitch it to the front. And this is the way how to the post-operative management of these patients. And return to sports in these patients is about 6 to 9 months. Next. आगे करें. News. उसे बाहर करो ना, जहाँ पर ठीक है. The other technique is the all epiphyseal cell reconstruction, which has been popularized by Anderson. And basically what you do is you drill a hole through the epiphysis of the tibial epiphysis, and the same on the femoral side. And then you pass your, and you do exactly the same you do in adults. You take the soft tissue graft, and then you pass it through using endo button on both sides. ये क्या हो रहा है? ये वीडियो ज़रा चला दीजिए. So the same, you take your graft, you make a graft exactly the same way as you're doing the normal instance. So this is about 6 to 6.5 millimeter long graft, and then you make a hole through the tibia. And the femur, you have to make a hole under image guidance. So this is the hole here, and this is the image guidance here under image intensifier. So this is the hole somewhere here. And then what you do is you pass it the way we'll do it in adults. So it goes through the physis of the, completely through the physis of the tibia and the femur, and you just put endo buttons on both sides. So this you drill it transversely under image guidance, you go completely epiphyseal. And for the tibia, what you have to do is you have to go quite interiorly, because it is only this place you can make about a 30 millimeter tunnel. If you go on either side, then it becomes very difficult to make that long a tunnel. इसको आगे करें यार. The partial transphysial is especially the center of the tibia physis. Actually, it fuses to the rest of the bone earlier as compared to the periphery. So here it will close early as compared to on the side. So what you can do is you can go in the center of the tibial physis, so you can go transepiphyseal in that area. But on the femur side, what you do is you go completely through the physis. So this will be a partial transphyseal or the hybrid technique. And this is completely transphyseal the way we do it in adults. Now the soft tissue we have to use is the soft tissue graft. If you use an allograft, then there are about 3 to 4 times of higher chance of failure if you're using an allograft in these patients. Now the important question is which procedure and when. Now this was actually a study by Patel, and actually this was basically a survey of all the members of the US Orthopedic Society, the POSNA, and actually wrote to them and just trying to find out what they will do. So this is basically for females, and this is the different age from 9 to 15 years. So this is MM is the modified Macintosh or the top technique. AE is the all epiphyseal, in which you put the holes to the physis on the tibia and the femur. H is a hybrid when you go transphysial on the tibia side and complete epiphyseal on the femur side. And TP is basically the transphysin. And if you look here, and this is basically, so this is basically survey of the pediatric orthopedic surgeons in America, that what they will do at sort of a specific age group starting from, say, 8 to 15 years of age. So it's from 8 to 15 years of age. So if you look here, the younger the patient is, the more the chance that they will have, and this is this is for the females, right? So the more the younger the patient is, more the chance of having or the top technique or the modified Macintosh and the all epiphyseal. But round about the age of, say, 11-ish, the all epiphyseal peaks, and then both of them go down in frequency. And the hybrid sort of goes up in frequency round about the age of 11. And then, so till about 11, 12, majority of the surgeons, they would either do a modified Macintosh or all epiphyseal technique. And this is for the male, so that was for the female, and this is for the male. And so if the female, this peak is around about the age of about 11 to 12-ish, right? But in males, that sort of intensity is maybe around between the age of 12 to 13. So they are sort of 1 year late, just because that males tend to mature later than female. So this was just a sensation. The greater variations was between, and this is basically, as I told you before, this was basically a survey of all the pediatric orthopedic surgeons in America, that what you will do to a senile injury between the age of 8 and 15. So the greatest variation was between 11 to 13 in female and 11 to 14 in male. But generally speaking, up to age of 8 to 10, majority of them suggested that modified Macintosh is the procedure to do. All epiphyseal, the peak use was at 11 in both age groups. The hybrid, people starting doing hybrid about 12 in female and 13 in male. And after the age of 13 and 14, you can actually go transphyseal.
Sir, we're
13
almost out
in,
of time. Can you just finish it up quickly?
Yep, 13 and 14 in male. Just finishing now. And so this was the suggestions based on the study as well. So less than 10 years, this was particular. 11 to 13, you can do hybrid transphysial in girls. And this is just the growth disturbances. So keeping this, you can actually see the growth disturbances are not that much as previously predicted. The re-rupture rate, and the important thing is that there is a higher chance of re-rupture as compared to adults, so 19% regardless of the technique. Another thing is that there's a 7% chance of the other side also rupturing. And the growth problem is situated with these techniques, especially the top technique is the valgus. Transepiphyseal, there is overgrowth, total epiphyseal, there is overgrowth, while in hybrid and transphyseal, there is increased chances of valgus deformity. And the future preventive techniques, combination with AL, people are thinking about it as well. So in summary, acid injury in the children is as rise. Prevention programs are effective. Early reconstruction can decrease the damage. There are increased chances of re-ruptures are high as compared to adults. And autografts have a lower failure rate as compared to allografts. But the important thing is that, especially in children, the return to sport should be at least after 12 to 18 months as compared to male. Thank you. Any questions?
Thank you so much, sir. We are short of time, so if there are any questions, so you can keep with yourself. If there is time, we can discuss it then. Thank you very much. So please, next talk is on the shoulder instability in young personnel. And I'm going to invite Dr. Kashif Mehman. Sorry. Okay, so. Okay, so we can invite for the same talk, Colonel Nadeem sir first. Thank you.
इसमें loaded है. Bismillahirrahmanirrahim. We know that wherever the art of medicine is loved, there is also a love for humanity, said by Socrates. I'm Dr. Nadeem. I work in Combined Military Hospital, Rawalpindi. So I'll be talking about briefly shoulder instability. We know that the shoulder is like a ball on a socket joint because at one point there is very limited amount of humerus head which is in contact with the glenoid. And this cavity is deepened by the presence of the labrum up to nearly around 50%, and that allows the type of movements which joint goes through. But inherently unstable, this joint is supported by the ligaments which are there, which is covered by the capsule from muscles in front, on top, and on the back. And that allows the deltoid to move the arm once those muscles are providing the concavity compression effect and keeping the center of rotation where it is supposed to be. So that is the job of rotator cuff mainly. So that is how it works. So what it actually does is that it resists the displacing force which is trying to make the joint unstable once it is moving. So the rotator cuff provides that concavity compression effect which deepens the further deepened joint by the labrum. And you need a more force to displace this joint out of the socket now because of any event which is trying to push it out. And that is how it is possible to have such a versatility of movement in this joint, which no other joint probably has. But we know that it's such a small base underneath, a big joint underneath, so it is always there, a tendency is to slip out. And once this joint slips out, it always takes something with it. It can take the portion of the bone, and this typically occurs in a hyper abduction, external rotation, and the force is coming from behind, the most common position in which our body responds once we are trying to fall. So this is what it does. It moves the head and it damages the structures in front, and the head of the humerus tends to come and get trapped and get impinged by the sharp glenoid cavity which is there in front, and that produces the typical Hill-Sachs lesion which is normally noted on the images. So if this keeps on happening again and again, so with each force, with each dislocation, the further damage keeps on happening to the bony surfaces as they are gliding past each other with each dislocation. And that changes the bony anatomy of the glenoid and brings into abnormal version. So these are the complications which can happen as a result of the recurrent instability which results because of this. And then you can have various shades of it to an extent that it can be easily dislocated. So this was the person who initially described the lesion, which normally happens, the labrum avulsion of soft tissue from the glenoid. So it has been classified as Bankart, osseous Bankart, or reverse if it avulses from the posterior. So we know that once it happens once, it is going to happen again and again. So the chances of having it recurrently are going to be higher unless you do something with it. During the first episode, if the patient has adequate physiotherapy, guarded ones, so every structure, if it heals, it's not going to fall back. But if it does not, then you can have the high chance of recurrent instability, especially if you're young, if you're involved in competitive sports, and it is compounded if you have additionally the hyperlaxity. So what it results in, it leads to the osteoarthropathy ultimately if it is left unchecked. So the diagnosis is not very difficult. If you know the exact pathophysiology, you can take proper history and ask for relevant investigations. There is a specific rehabilitation program which you have to go through. So the aim is to do something with it so that the individual in our setting especially has to perform duties both in peace and in war as well. So just to give you a brief overview of a case, so this is a patient who was young, who was 23 years old, who is going a rigorous initial induction training into the forces. So he had just an awkward fall while he was crawling through with all the backpack and the weapon. There was not a major event which happened. He was just trying to crawl and awkwardly fell. And he just relates all the symptoms to that event which happened at that time. And he was continuously complaining of pain and clicking in his shoulder since then. He was doing all his running and all those other activities, but he would try to dodge all the activities which were related to anything which would put his shoulder into that position of instability. He had 1 visit, 2 visits, 3 visits, and finally presented to us. So he had the obvious positive sulcus sign anteriorly. Once you try to move this shoulder in front, so it will definitely like to move more anteriorly than posteriorly because the anterior structures are gone and the posterior are still intact. His shoulder was painful in the extreme of abduction and external rotation. Rest of the examination. So he had this hyperlaxity as well. So he was 4+, apprehension test being positive. So in such a case, you always do to rule out the other injuries to these patients, that you need to rule out that this patient is not having additional injury to his cuff or tendon, especially the biceps tendon. So you'll do all those tests. So this patient had an initial X-ray which was labeled and reported as normal, but if you look through these X-rays very carefully, you will find out that this head is not sitting where it is supposed to, and it has lost its center of rotation and has moved interiorly slightly, so which is a subtle sign of instability in such patients. Definitely we will ask for an MRI, or if more specifically MRA, and that will show you that the Bankart or labrum interiorly is not there. So in this patient, there was an anterior-inferior invulsion of bony plus clinoid labrum. So we put the patient on V-chair position. In all these patients, I always try to do the dry arthroscopy first, just to see what is happening, and we can appreciate that there is something wrong with the anteroinferior portion of the labrum there. The pointer, I think, probably is not taking me there. So you can note down there is some cartilaginous portion along with the soft tissue portion which is gone. Next, please. It's not moving. You establish the interior portal, you put in the fluid, you probe it, and you can easily pick up that it's not there, there's a avulsion grossly there. So debridate with the shaver, with the ablator, freshen up the margins, and then you sling it, and then you fix it back where it is supposed to be. And then you check whether everything has been properly fixed or not. So these patients then definitely go through a specific rehabilitation program to get their range of motion back. Next. So in our setup, we have done around 20 plus cases so far. They are in various stages of their follow-up. Most of them are definitely military because primarily dealing with the military. They are mostly young. And most of them associated with some traumatic event, specifically once you ask them. Most of them were unidirectional. They were not multidirectional. And they had intra-articular avulsion as stated in the literature. And these patients, especially if they have recurrent instability, have other associated lesions which develop, and they have a high chance of recurrence of instability if you do not identify and handle that other associated injuries in these patients. So I would like to conclude by saying that persisting activity-related pain in shoulder after a traumatic event can be a sign of instability, and if you don't treat it, it can lead to irreparable damage. Thank you.
Thank you very much. Thank you very much, Dr. Nadeem. I think you covered pretty much of Dr. Kashif's talk as well. Dr. Kashif? So I will just request you to be quick, just for the sake of time, so that we can start our next session. Dr. Kashif Memon, he will cover the clinical aspect of the same topic.
My name is Kashif Memon. I'm one of the upper limb trauma surgeon in Queen's Elizabeth Hospital, Birmingham, which is one of the which is second biggest city in the UK, and our trust is a third biggest trust in the UK. We cover 4 different hospitals. We cover civilian as well as military patients as well. So this particular talk is about the in the forces patients, not in the civilian population. So shoulder instability has a nearly 10% greater increase as compared to the general public in the forces population, according to one of the military literature. And next, please. Male gender, young age, and participation in contact or overhead activities lead to the most common pathologies in the forces people. Next, please. So arthroscopic technique have suggested advantages that includes less loss of motion, lower risk of subscapularis failure, quicker return to sports, and a higher patient satisfaction. Next, please. Recent review by the one of the military journals shows that. Can you quit, please? Recent review of clinical outcomes suggests that arthroscopic technique is a gold standard as compared to the open techniques, and variety of factors have shown to predict the outcome of arthroscopic stabilization. The key issues for the arthroscopic stabilization is glenoid bone loss and early intervention. Next, please. Dickens showed that while average glenoid bone loss is 6.8% after the first time instability, but with a recurrent instability or recurrent dislocation, it can go up to over 22%, which resulted into the critical bone loss. So that means patient needs open procedure as compared to the arthroscopic procedures. Next, please. Saha showed that in forces population, critical bone loss is it should be considered over 13% rather than a general population which is over 20%. Next, please. While Owen found that stabilization performed early results in better outcomes as compared to the stabilization performed in later situations, regardless of technique, whether you are using the arthroscopic technique, whether you are using the open technique. Next, please. While Gasparani showed that patients who underwent surgery with after first episode of the dislocation have lower rate of recurrence as compared to the patient with a recurrent dislocations. Next, please. So we have done this study in our hospital, and the aim of this study was to see is that labral tears experienced by the serving UK forces personnel undergoing arthroscopic stabilization is same as compared to the civilian population or not, and to assess the reliability of the preoperative diagnostic methods, arthrogram versus clinical examination. And the final outcome was to see the outcome of arthroscopic stabilization in terms of satisfaction, pain, and return to the full deployment in the forces population. So preoperative demographic and clinical data were collected for all the patients during from the September 2016 to January 2019. Patients who were established preoperatively as requiring open procedures, they were excluded from this study. Next, please. Clinical examination included all the tests for anterior instability, posterior instability, and superior instability. Preoperative MRI results were reviewed and compared with the reports with a shoulder surgeon and a radiologist. Next, please. In our study, we got 41 forces patients who all went under the arthroscopic stabilization. And the follow-up for those patients were 2 years. So those were either telephone or face-to-face appointments. And at the final follow-up at 2 years, all the patients were seen with face-to-face appointment with clinical examination. And we have done the outcome by years with a PROMS data as well as occupational outcomes were gathered. Next, please. So the outcome measures included return to sports, return to deployment, PROMS for the visual analog score, Oxford Shoulder Instability Score, and Western Ontario Stability Index. Next, please. So this slide shows the preoperative MRI versus the clinical examination finding and arthroscopic findings. So the first row shows the anterior tears, which shows on the MRI and on clinical examination it was 8, while on arthroscopy we found that 2 more patients have anterior tears. Posterior tears on the MRI it was showing 4, while on the arthroscopy it was 11, which show the difference between arthroscopy and MRI. The interesting thing was the pain labral tears was 4 in the MRI, while on the arthroscopy it was 11. So it was over 25% as compared to the literature, which suggests the pain labral tears usually is around 6 to 7%. Next, please. So in our study, we have total 41 patients. 39 were male and 2 were female. During final outcome, 8 patients were not contactable because they were either deployed overseas or they left the military. We have got 80% follow-up. Mean age was 29 years, and dominant mechanism of injury was either direct fall to the onto the shoulder, followed by rugby, weightlifting, and football injuries. Out of those 41 patients, 12 patients have reported dislocations, while 16 patients have subluxations rather than dislocations, and 14 patients presented with pain without any episode of dislocation or subluxation. Next, please. So the mean time from injury to surgery was 20 months, and mean time from referral to surgery was 6 months, because there is a referral system in the UK. So patient need to be seen by GP or forces medical practitioner first, and subsequently they are referred to the specialist units. And mean number of instability events in were over 2. Next, please. So all the patients have gone shoulder arthroscopy in the lateral position with a 3-point traction tower with a posterior lateral, lower anterior and anterior superior portal. Entire labrum was inspected and probed while viewing from the posterior lateral and anterior superior lateral portals. Next, please. So out of those 41, 3 patients have bony Bankard and 2 patients had a critical bone loss over 20%. So they were converted to the open lethargy procedure. So they were not included in those studies. Next, please. When compared with a intraoperative arthroscopic findings, MRI was found to have sensitivity of 63% in anterior, 50% in posterior, and 94% in superior labral pathologies, while accuracy was 78 for anterior, 68 for posterior, and 98 for the superior labral pathology. And the negative predictive value was 65 for anterior, 54 for posterior, and 96 for the superior pathology. Next, please. Next, please. So postoperatively, all patients experienced improvement with surgical stabilization. Mean length of follow-up was over 26 months, and mean visual analog score at rest was 0.8, and during forces fitness test, which I believe is a very extensive test, was 1.8. And there was no episode of real dislocation or subluxation reported by those soldiers postoperatively till the over 2 years' time. Next, please. Of these patients, 82% over 82% returned to full redeployment with a mean time of over 10 months after surgery, while 2 soldiers were permanently medically discharged for non-musculoskeletal related conditions, not from the shoulder point of view, and 2 remained temporarily downgraded due to knee injuries, not because of the shoulder injuries. Next, please. There was no significant difference found between length of time from injury to surgery for those soldiers successfully redeployed, and those are not. There was no direct significant difference in postoperative Oxford shoulder score or WOSI score for those who were successfully redeployed and those who were still not redeployed or had been discharged. 85% of our patients returned to sports with a mean time to return was over 7 months, including gym, weightlifting, CrossFit, football, running, and golf. Next, please. So the prompts for the Oxford shoulder instability score, all the patients, which was 80%, completed those scores pre-operatively and post-operatively. The mean pre-operative Oxford shoulder score was 18.58, while mean post-operative Oxford score was 41, with a mean improvement of over 21 points. Next, please. So this table shows the pre-operative versus a post-operative and improvement in the shoulder scores. So in the overall score, I don't know why it's not working. Huh? This does the screen. Okay, that's fine. Leave it. So the overall improvement in the score was 21.64%. Next, please. Next, please. While the PROMS data with the Western Ontario score was, because those WOSI score was done only post-operatively, when they compared with the Oxford score, it was showing overall improvement. Next, please. And that's the table shows WOSI score. The WOSI score was mainly affecting the physical and sports activities, not the lifestyle or emotional things. Next, please. So our data showed that there is a high rate of complex tears in the forces population as compared to the civilian population. And the American study suggested that there was a rate of around 9 to 18% with the multiple zone injuries. Thank you. Next, please. there were certain limitations in our study because during that time we have 3 civilian surgeons but 1 military surgeon, and this study was conducted with 1 military surgeon, and it was retrospective. And there was time difference, say, between the MRI and surgery because of the referral system, which might have allowed pathology to evolve over the time. Overall, 41 patient was small number overall, but it was the biggest study in the UK, and it was the second biggest study after the American studies, and there is no other study available in the world. So our study was the second biggest study. Unfortunately, we lost 8 patients from our PROMS data, leaving with a 80% follow-up rate. Next, please. So this study highlights the importance of clinical examination for the both surgeons who treat the patient and for the primary care physician who refer the patient to the specialist unit. The outcome presented in this study suggests that even high demand users can expect improvement following surgery, given the risk of increased bone loss with recurrent instability. So we would argue that early intervention after first event should be considered rather than managing all these patients conservatively, and they may develop the recurrent dislocations, which may be a difficult problem to address and which may be converted to the open procedure with a different type of complications. Thank you very much. Do you have any questions?
Thank you very much, Dr. Karthik. We're skipping question and answer session for later on.
Okay.
So for the sake of time,
okay.
Thank you very much. Thank you very much. I'll just try to be as quick as possible. I know the foot and ankle guys are desperately waiting and furiously looking at me. Can you just start the talk, please? Is this session 2? So thank you very much. The question is when to augment your ACL. There are certain scenarios when we think we need to do more than just ACL reconstruction. So what are those scenarios? What are the clinical symptoms when we see in our patients? Then we think we need to do just more than ACL reconstruction. There is synthetic augment. This is just a disclosure to what I'm going to show you in the next slides. Thanks to all my mentors who helped me navigate through my career to this day. Why we need to augment. There are certain questions that pops in our mind when you see patients like these. So you see a patient like these coming to your OR. When you examine the patient, you see this kind of pivot shift, which is clearly evident and helps elucidate rotational instabilities as well. So definitely you think that there's a lot more going in this knee more than just an ACL. So it could be a cartilage, it could be meniscus, it could be rotational instability, posterior medial lateral corners, and then it could be posterior tibial slope that must be bothering you for the surgery. So we need to keep an eye on recurvatum, mechanical alignment, and then, of course, is it a primary or revision case? So we do consider these kind of interventions to just augment our graft so they never fail in the first place. So definitely it needs more than just ACL reconstruction. So modern day ACL armamentarium includes from primary ACL repair to augmentation to reconstruction. There are viable options, so any ACL surgeon must have these options available on the table behind. Synthetic augmentation versus lateral extra-articular procedure. What we do, I'll just share what I do in my practice back in Faisalabad, from synthetic augmentation with the use of fiber tape to adding an LET, which is lateral extra-articular tenodesis, in which cases we do it beginning from fiber tape. It's a synthetic device used as an internal brace, sufficient strength and very limited joint reaction and cartilage reactions that has been shown with biomechanical studies. Why internal brace and why do we use it as an internal support? Because there are patients who are at risk of graft failures. There are patients who are at high risk, like young patients who are, they might go back in the game and re-tear their grafts, and the other high-risk patients with injury, poorer outcomes with the revision rates. So we do make sure we just want to do something extra. So accelerated rehab in elite athletes who want to return to sports quickly, and then there is decreased need for external brace in these patients.
It helps prevent stress elongation of the graft, which I'll come back to it later on, and definitely it's a seat belt concept just to protect your grafts throughout the rehab. It kicks in at higher loads and it shares the load when the loads are higher. Who is high risk? Of course, all the young patients with generalized laxity, pivoting sports, and coming up to you with high-grade pivot shifts, showing subtle signs of significant grave injuries like Seagon fractures, chronic ACL injuries, lateral femoral notch signs, elite athletes, and malalignment with posterior tibial slope more than 12. Fiber tape as internal brace has been studied extensively in the literature. A lot of evidence coming in this support for the last decade, so I will not go much into the detail. Its safety data has been suggested with no synovitis and no cartilage damage when it's inside the joint. So fiber tape is unique feature. It's an independent load distribution with no stress shielding, dynamic safety belt effect. It's load sharing at higher loads, higher failure loads than the ACL graft itself, which is surprising, and it has reduced elongation. More evidence kept coming on in the favor of this thing to be used as an internal brace like a seat belt inside the joint, and the concept was the synergistic load sharing, which really comes out as load loads on the graft until displacement begins, and the fiber tape engages at higher loads to reduce the loads on the graft, so no stress shielding. Augmentations versus reinforcement, that's another concept. This is how we do it in our grafts, just to put it along the graft, just make a sturdy, solid, robust construct. That's how it looks like, increases in the diameter, and that's how it goes inside the joint, the graft construct. That's how it looks like when you put it inside the joint. You can just put it outside. It could be buried inside the graft, as in the other one. And we do need to fix it back on the tibia as a backup fixation just to complete our seat belt concept, regardless of the technique you are using, if it's all inside, if it's the standard with the bias screw on the tibia. So we just fix the fiber tape on the tibia either with the help of civil lock or soft pitch suture anchors or with the suspensory fixations. The next step is to put in the screw and the tibia, and then I evaluate my knee as perfectly stable all around, quite confident and comfortably I could go home. Further studies came out in favor of fiber tape as a synthetic augmentation device to be used in high-risk patients, especially in athletes like these who are performing at elite level, go back to the game at early space. Both are national champion. First is playing from the Army, and the other one is table tennis national champion from Faisalabad. So key points, take home, I do consider these things in ACL revisions. When the graft diameters are 8 mm or less, high-risk patients, non-compliance is expected, especially in the primary ACL repairs. So at the technical points, the fiber tape parallel to the graft, insert the graft, will construct in UL manner, independently fix the fiber tape in extension, and then retension the graft to femoral side later on. The next emerging concept was the augmenting the graft from lateral side in the form of anterolateral ligament reconstruction, or the LET, which is lateral extra-articular tenodesis. So two major lateral augmentation procedures. We all know what anterolateral complex is, how it is made, how does it perform in controlling the rotational instabilities. Good evidence is coming in, the JBJS stating that it definitely controls the rotation, and it has great impact on the knee, anterior translation and rotations, especially the superficial IT band that has a major role in it, and it's crucial, and it plays more important role than ALL in restraint and 30 and 90 degrees of knee flexion. So ITB is the key structure here. So that's the reason I prefer LET over ALL. Both the procedure combined and shown in the picture has their own pros and cons. With LET, the greatest advantage is no more tunnels, no grafts, and the graft lies above and just below the LCL, compared to the ALL where the graft lies above the LCL. An emerging stability trial, one of the famous trials in American Journal of Sports Medicine, stating that statistically significant and clinically relevant reduction in graft rupture and persistent rotator laxity at 2 years in trouble if we add this procedure along with simple ACL reconstructions. One of the cases we did in Faisalabad, examination under anesthesia, you see there's a gross laxity, anterior door is positive, and then we just proceed with the pivot shift. It's high-grade pivot that tells me that something else is going on inside the knee, whether it's the biomechanics, conformity, it's the shape, it's meniscus, it's cartilage, or anything else. We need to look down. And then I performed augmented ACL reconstruction on it, checking my stability on table, and you see the landmarks are on there. It's a pre-surgical decision exactly, so we just decide before the surgery, before embarking on the ACL reconstruction, that we need to go for it. So lateral extra-articular tenodesis, these are the steps. just 3 to 5 centimeter incision, leave distally attached on the Jetty's tubercle, save the posterior capillary fibers. So this is how the graft looks like. It should be just roughly 1 centimeter wide and 3 to 5 centimeter long. Graft is 5 centimeter length, pass below the LCL, and then we just fix the graft proximal and posterior to the lateral epicondyle, just to avoid ACL tunnel that has already been made. It's just a small incision which we can just fix a neutral rotation. That you must keep in mind. With 30 to 60 degrees of knee flexion, you could use any device from staples to anchors to screws, anything that you're comfortable with, but just make sure it's not too tight to just add an extra stress on the lateral compartment. Right after the procedure, you see the negative pivot shift, anterior drawer, it's perfectly stable knee in all directions. So lateral escargot has pre-surgical decision for high-risk patients coming to you with posterior tibal slope more than 12, with malalignment, extensor recurvatum, high Byron scores, meniscal cartilage defects, for grade 3 pivot shifts, and of course in ACL revisions. About these procedures, take home is just the ACL reconstruction is not one size fits all, as we were discussing before. It's different for different patients, so we need to educate the patient to set expectations, and then right graft for the right patient must be chosen, and I never compromise the graft diameter, which is, from my cutoff, is 8.5 mm and more. So we always want to think beyond just an ACL reconstruction. I add augmentation, it decreases stress on graft, I add LET, so we need to make sure we need to put every extra effort just to make sure to get it right at the first time, because revisions are not easy. One of my recent experiences at FIFA Center of Excellence in Doha, an amazing experience, how they manage the sports injuries in the FIFA World Cup and what are the different and innovative optimizations in the sports rehab and ACL reconstructions. So I was fortunate enough to be there and presented my cases in front of globally renowned faculty there from Australia to US. So we just had a lot of consensus on different cases, starting from the ACLs to LETs to LL reconstructions. So we just look forward to bring this back to Faisalabad and start practicing over there. Thank you very much for your attention. So with this, we move on to the next session. If you have any comments by the panelists, I would just encourage.
Thank you very much, Osama. Before we close the session, I would like to thank the audience and the faculty for being patient. Unfortunately, we were running late with the time, so we could not have as much discussion as we had in the last session because our colleagues for ankle and foot section, they are waiting for their overseas speaker who are already on the Zoom. So thanks a lot, but before we say goodbye, I would request Kashif Saab to give his comments.
I think it was a very nice session. Just one question, Osama, regarding this LET. So how much is your the long-term these outcomes?
We have so far followed our patients till almost going to be 2 years soon, but we have very few patients, around 14 or 15 so far.
Yes.
But a few patients came back to me involving in pivoting sports, like the part I belong to is a huge hub for the kabaddi. There are very huge athletes that area produce. They are involved in the contact sports. And one of the patients, I performed LET, and they came back to me after a severe injury. So the day I was convinced totally on it that his LET graft was affected, but the ACL was intact. Okay. So this is how it protects your graft. It's amazing. So I myself used to convince myself before I embarked on it, but it definitely helps.
The concern is that there might be forces on the lateral compartment be too much, and it can create the lateral compartment arthritis. So how long is the follow-up in general?
That is the key, actually. I mean, we need to just make sure that graft is not too tight in that situation. So it's just an extra check-in on your ACL. So it's not too tight. It's just in the 30 to 60 degree of knee flexion, and just make sure it's neutral rotation. And there are queries on it, and there is a literature on it, but there is still no convincing evidence to make an impact to change your practice that you should not do it. So there are evidence on it that some people are think and believe that it can cause an extra stress on lateral compartment, but same does the ALL reconstruction. So it's the same, but it's still the growing evidence, and we cannot say anything about it.
No, it was excellent. I think we can take a couple of questions if you don't mind.
Actually, sorry, we are quite short of time.
Okay.
And run late.
Sure, one more comment from.
So if you cannot obtain stability on the table, you can never expect stability afterwards.
Exactly.
So that is how you are sure of it, that you have, okay. But particularly when you are testing for the stability on the table, your patient is anesthetized. Everything is lax.
Yeah.
And when the patient start loading the knee, what about that instability? Is there any difference between the two instabilities obtained at the time of surgery and subsequently after 6 months? Do you relate with each other?
So that's a great question, but it depends on the graft we are using, the patient you are treating, if the patient has...
It is stable on the table.
Yeah,
and
perfectly
subsequently,
stable. If you are
after
using,
6 months.
Yeah, if you're using hamstring grafts has a problem with it. They go down in early 4 to 5 months and they lose their strength. You could see micro instability in there. That's how to define in the literature. But still, that's gone with the perfect rehab and all that. I had those patients with me, but when we just put them in the right rehab, they went to the right physiotherapy, so it was perfectly covered. But I do agree, there is a slight difference and subtle changes on table and actual life scenario.
Good enough. Thank you so much.
Thank you
so
so
much. It was a very
much.
nice session.
Thank you, sir. Thank you very much.
You are moving on to the foot and ankle session?
Foot and ankle session.
Yes. Okay, thank you so much for the session. Okay, so we are going to conclude the session, but before going to conclusion, I request Shah Saab, who is the chairman of the Sports Surgery Forum, to come to the stage to distribute shields among the speakers. हाँ जी आप तरतीब से करें नहीं ये नहीं काशी में इसमें जी ठीक आप अच्छा अच्छा ठीक है ओके Okay, I would request Professor Zajaskar Saab to please come to the stage to collect his sheet. ये sheet तो लेके जाए ना आप फिर इनके फिर कौन थी इनमें से वो सामान चला गया जो है ना अच्छा सर्टिफिकेट है Okay, thank you very much. And now you request Dr. Kashif to collect his shield, please. और किसकी शील्ड? हाँ ये वाली, ये लीजिए। ये वाली है। और किसकी है? ये भी है ना काशिफ में मुझे दो। अच्छा ये मेरी है, फिर ये आपको नहीं मिलेगी। Osama चले गए। और कौन? Okay, please now I request Osama bin Said to collect his shield. वो बाहर चले गए शायद। उनकी शील्ड कलेक्ट करने के लिए कोई नहीं। Okay, now I request Dr. Shah Sahab to give me the shield. Thank you. Okay, I would request Faizal Shah Sahab to please come and collect his certificate from Professor Zaidaskar Sahab. ले देना
सर्टिफिकेट
बच्चा आपका नाम Okay, thank you. And I would request Dr. Sabir to collect his certificate, please. Thank you so much, sir. Thank you. सारे सिस्टम में किससे नहीं कहा क्या तुम्हारा टाइम फिर में बंदा छोड़ के तुम्हारा टाइम खत्म हो गया सिलेक्शन में आराम आराम से हर टॉप इम्पोर्टेंट है
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you for joining the foot and ankle session. My name is Dr. Tashfeen Ahmed, orthopedic surgeon from Aga Khan University, Karachi, and I'm the Secretary General of the Foot and Ankle Forum of the Pakistan Orthopedic Association. Our chairman of the forum is Dr. Manullah Kakar from Quetta. He unfortunately couldn't get the flight to come here, so he has sent his warmest regards to all the people in the hall. And we will inshallah start our proceedings now. So for chairing the session, this year in fact we have panelists instead of session chairs and co-chairs. So as a panelist I would like to invite Professor Irfan Mehboob from Lahore. Professor Irfan Mehboob, can you please join us on the seats for the panelists? And the other panelist that we would like to invite is Dr. Harun Majid from UK. He's a foot and ankle surgeon working in Manchester, UK. So welcome, Dr. Harun. Please have a seat. So I'll start. The first talk of our session is on ankle arthritis, recent advances. And for this talk, I have the pleasure of inviting Dr. Suhail Yusuf to come on the stage and deliver his talk. Dr. Suhail Yusuf is one of our people who have supported the forum in its academic activities, various workshops, and almost all of the foot and ankle sessions that we've done in Orthocon. He has been a part of that. Thank you, Professor.
Thank you.
Over to you.
Thank you, POA, for inviting me. My talk is very detailed, so it may take some time. Can I put the presentation on, please? Next slide, please. That's my introduction. Next slide, please. Next slide, please. Next slide, please. Next slide, please. Next one, please. Next one, please. Okay. Can you play the video? Can anybody tell or care to look at it to see what operation this patient had on his ankle? Can we run it again, please? Spare your thought in your mind. As the topic of my talk is recent advances, can we move to the next slide, please? So these are 3 ankle arthritis scenarios which I see in my common practice. I'm sure in Pakistan, when I was working, I have never seen them because the arthritis will be much more severe. These are typical from right to left. A middle-aged man who's still working, has pain at rest as an activity. He owns a farm and walk a lot and would like to have some pain relief for his problems. He has tried analgesia, shoe modification, etc. The middle one is slightly more elder, very similar problem, but quite significant deformity clinically on the ankle. And the further left again, slightly younger again with more severe deformity and pain, activity, and functional. So let's move to the next slide, please. This is the first case. This gentleman, only look at the lateral view, there's other issues. Which is, although x-rays showing that arthritis seems to be in simple one corner, but if you do further imagings, there's more arthritic changes. I offered this patient an arthroscopic ankle fusion. It was a quick operation. He was able to get up and walk in a plaster after about 2 weeks in a plaster, and that plaster was moved in 10 weeks, and he has pain-free ankle. The next patient had more functional demands. He has subtalar joint arthritis as well. So this patient had a total ankle replacement. It's very hard to decide which one is a good candidate for ankle replacement, which one is for a fusion. But if you talk to the patient, you can make this decision. My third case, again, arthritis with the deformity, although the deformity was slightly severe than the first case, but it was still correctable on table with a simple arthroscopic intervention, and he had a fusion, again, with very good results. When I look at these patients, clinically, I cannot distinguish which patient has done well or bad. The results were actually quite comparable in the first first year. So there was no differentiation between ankle replacement or an ankle fusion. So what is the new in ankle arthritis? And I will simply say this is the most talked about study in foot and ankle world, where there's a multi-center randomized controlled trial comparing ankle arthrodesis versus ankle fusion, and the results are not similar, dissimilar to what I have witnessed in my clinical practice. The results are more or less the same, but if we look in more detail, the patient with end-stage arthritis with fixed fairing implants do slightly better than a ankle fusion. And after years of planning and doing a lot of research, this probably is the most remarkable paper on ankle arthritis and getting a lot of attention all over the world. But the results are what we were expecting, is no dissimilar. But what it suggests that ankle replacement actually is not a bad operation. For good pain relief, you have to consider the demerits by doing a ankle fusion or a revision procedure at a later stage, but that's depend on patient to patient and risk stratification. That will be my, I don't want to spend too much time. This is, can you play this video please, if it's possible? This is one of my patients which had an ankle replacement in 2 weeks' time, and his wound is healed and he has reasonably good results. He's moving well, and 1.5 years down the line, he hasn't raised any concern with me. The other advances in our part of the world is that the incisions were longer. We were having problems with wound historically, but now we have got patient-specific implants. The results are good, but we do not have any long-term data. This is one of the other recent advances. I don't want to dwell too much time on what else we do. The one thing we do as a clinician, we discuss these cases a lot for appropriate selection of the patients. We do have an MDT setup. Every single case is discussed among a group of patients, which one is suitable for ankle replacement or ankle fusion. Not one person is making a decision. In the same count, not one person is doing the operation. So we are 2 surgeons. We do this operation. We do have network meetings. We do regular training sessions. I have formed a team. And what I have realized that with ankle arthritis, there is an increasing demand for surgical management of these patients. There are good quality implants becoming available for ankle replacements. The techniques for ankle arthroscopic is improving, and less patients are having open ankle fusions. I certainly have not done one for 4 years. Shared decision making is helpful. I would encourage anyone, if you are in a difficult situation, ask a colleague or a friend who can give you some advice. I do a surgery with another consultant colleague. It is helping me to learn from my colleague. I also train someone. And sometimes with long operations, you are thinking too much about the surgery and the surgery is not moving forward, and the second person is just someone who can help you to make quick decisions and can look after things around the team. That's where I work as a treatment center, one of the largest in the UK. We just do joint replacements. We have 6 theaters running. That's my team, that's my contact details. If anybody has any question, please send me an email. Very happy to get back to you. Thank you very much. That's my presentation.
Very good, Sahil. It's a very nice presentation, and particularly with the innovative treatment like the ankle replacement surgery. It's a very good, and the video was showing like that's the beginning. I thought he had an ankle fusion, but it was the replaced ankle particularly with a very good movement in that. But what do you do for the fibulotalar arthritis? Do you replace the tibial talar area? And what is left for the fibulotalar? There's any residual pain with the fibulotalar?
It's a very good question. Sometimes there is a fibulotalar arthritis as well. That has to be identified before surgery because the ankle replacement will not resolve that issue. you will get pain from the fibrillar arthritis. That patient is not a suitable candidate for ankle replacement.
So that may be a candidate for the ankle fusion.
Ankle fusion, I always inject in the ankle before I do a surgery. That injection is done 6 months in advance. I monitor their response to the injection. If they respond well, all the pain or majority of the pain goes away, then I talk to them about ankle fusion versus ankle replacement. If I'm doing a fusion, now I do not prepare the lateral and medial gutters. There are more and more data coming out that the patients of the fusion can have an ankle replacement at a later stage. For the young patients, we try to preserve the joint, the gutters, so we can proceed to do a conversion ankle replacement at some stage. If there are better implants available, a few years down the line, it is possible. For my initial thought on the first X-ray, one of my very senior good colleague from King Edward yesterday suggested that the patients are very scared of having a fusion because they cannot walk properly. My first case had a fusion on one side and a total ankle replacement on the other side. And he was walking without any obvious limp, if you have noticed. If there was a limp in that age group, you probably will accept that. So my take-home message is, I know you cannot, we are not doing ankle replacements here. We are doing ankle fusions. We can do ankle fusion. People are very good surgeons. It's just, you think the patient's life will be ruined, it won't. The life is ruined because they're in pain. Ankle replacement is not a good option when you not have enough support and facilities, but ankle fusion is a simple option. 2 screws and ankle will fuse, provided you prepare the joint well. And they do not limp. They do not limp as bad as we think. They will be pain-free. They'll be very happy. But if the time you spend to prepare the joint will sort out the problem. And the best way of preparing the joint arthroscopically, give your arthroscope to your registrar. Registrars are meant to destroy the joint with their arthroscopy. And they'll do a very good job. They will destroy the joint, and they will get rid of all the cartilage. It's a bleeding bone, put 2 screws across it. It will fuse.
And that's a good option.
Yeah. Thank you very much.
Get them do the job.
No, just a comment. I totally agree with Suhail Bhai's thoughts. Both are good options. Essentially, any ankle can be fused regardless of the deformity or patient characteristics, and it's actually a very good operation which has been in practice for last 150 years. Certainly, the techniques and the results have evolved, and it is a dilemma that I'll become disabled with a fused ankle. It's actually not. It's designed for those who are heavy physical builders, who go up and down the ladders in daily life, and it works really well if you counsel the patient well. Ankle replacement, on the other hand, yes, there is a narrow criteria of selection. It's not for everybody, but as the techniques and implants are evolving, it is also a very good option in carefully selected patients. But there's a learning curve, and the number of patients are a lot less compared to hip and knee replacements. So I think these are the limitations, but if you choose your patients well, counsel them well, do the surgery well, it works well, either side. Thank you.
But in our population, one of the major concern is that whether we'll be able to offer prayer or not while the ankle is fused. So what's the answer for that?
The main question is how they're managing to do prayer with the painful fixed ankle.
But somehow
They
the
will
other
not mix that. They do not have ankle movement. They're moving from the subtalar or the talonavicular joint. End-stage arthritis would not allow ankle movement. It's just you examine them, they will not miss that movement because their movement is not there anyway. They will pray in the same way where they're doing before, but this will be without the pain. That's what I tell. My patient will ask me the same question, how will I do, climb, hike, ride a bike? And say, you'll do the same way you're doing it before, but this will be pain-free. Okay. This operation is not meant to make you walk better. This operation is meant to take the pain away. That is the most important distinction for decision making. No orthopedic operation, no, I guarantee there's no orthopedic operation will make you walk faster or better. You walk better without pain. That's it. That's my take.
So you have fused it at 90 degree, I suppose. 500. Okay.
Thank you very much. Just one short question from me. Do you use power saw for preparing the surface?
Sometimes, but if it is a very arthritic bone with no cartilage, long standing, which is a very hard bone,
Yeah.
sometimes you use a bug in young patients.
Otherwise, normally?
Normally, just the soft tissue shaver, just like you do arthroscopy, get rid of the cartilage, I take a curette through one of the portals, I take a curette and take all the cartilage away. And then I do a bony shaver, 3.5 millimeter, and I use the depth of the shaver as a marker for my depth of the bone.
Right.
So as to the shaver goes down, that's my landmark, and then I go across from left to right as the 9 areas, 9 zones of the ankle, and I go from left to right, and my depth is as the depth of the shaver, and I look for any bleeding bone, fat tissues in the during my arthroscopy, and sometimes I just release the tunicate to see if there's any bleeding. I have to release the tunicate anyway to put the 2 screws. So it takes about 50 minutes.
Right. So what I learned was that the key is not to have the surface heated by the power saw.
Yeah.
In arthroscopy, of course, you have fluid and irrigation, and that burr is not as high energy as a power saw. So in some places, they only use chisels and don't use any power instruments at all. Dr. Harun, yes?
Exactly. I was going to add that I use hand chisel, sharp chisel with mallet, just gives me better control of the deformity correction and avoidance of heat. Again, a personal choice. Maybe there's not enough evidence to support that, but it just makes me feel more comfortable.
Right. Okay, thank you very much. We'll move on to the next talk. This is the next talk. We are going to skip modify the schedule a little bit because we have an online talk by Dr. Arshad Khalil from UK, and because of the delay in our program, he needs to go, so therefore I put his talk in the first part. So he's going to give us his talk on the pediatric flat foot. Dr. Arshad Khalil is a practicing orthopedic foot and ankle surgeon in Chertsey, UK. In fact, he's a colleague of Dr. Sohail, who you just heard. And so I invite Dr. Arshad Khalil for his talk on Zoom.
And I'm now going to bore you, hopefully for a very little while, with a very common problem that we all get to see. I hope you can hear me.
Yes, very well.
Can you hear me?
So we can hear you very well.
Okay. For me, pediatric flat feet is an exercise in detection and communication. It's very easy to identify flat feet. You stand behind and you see the obvious. And you ask the child to go tiptoe if they can. And we can see that there isn't a structural problem with the foot. And we also get to admire the beautiful engineering that the midfoot is, because this the reason why this works is that on tiptoe, the foot becomes a rigid structure, and on standing, the foot is a supple structure. Now, if your child can't tiptoe, then you can use the Jack's test using the whiplash to produce the same effect. So let's admire the physics of this. On standing, our transverse joints line up, which unlocks the subtalar joint and allows the foot to become a supple structure. The transverse joint has anterior and posterior facets, and you can see that why do we need a posterior facet? Well, the fulcrum is in the middle, the sinus tarsi, and this is what happens in a supple joint. If the ball and socket joint is too supple, the fulcrum moves behind and the foot rotates on the ball and socket. and you see the loss of Meary's line and the rotation of the foot. But there isn't a structural problem, because as soon as we move the fulcrum back forward, i.e. we make the transverse joints axis different, the foot is restored beautifully. So there isn't a structural problem. It's like, so this is the art of communication. Flat-footed children are like having a long nose. You may not like the length of your nose, but it isn't a medical problem. All children born are flat-footed, and as the sinews tighten up, we start to develop the shape of our foot, and that is mainly because the foot needs to change from a rigid to a dynamic structure instantly. Sometimes the parents give us extra gift in a collagen, and the sinews never tighten up. So these poor kids are going to remain flat-footed all their life. Now, the only problem is that this foot is not designed for running. It needs help, because what will happen is that the muscles that keep the shape of the foot tire out quickly, and these children will tell you that they can only run for a little while, and then they get muscle ache. Now, the exercise in detection. When you're seeing a child with symptoms of problems with the flat feet, who exactly has the problem? Because the happy, active, healthy child, it's not the child that has the problem. The parents are anxious and worried. Later on in life, the child can actually use the flat foot to avoid the things that the parents want them to do, because they've paid for lessons and gymnastics and other sporting activities that the parents think are important. And then you have the more older child who genuinely is frustrated and is in trouble, and it's easy to tell. So this is what I call the rainbow of presentation of flat feet. So the key question to ask is, why is the flat foot painful? We just worked out that there is actually no structural problem. So why is it symptomatic? And if you examine the child, they have pain on the instep, and they may have impingement on the outside. But the flexible flat foot produces a chain effect in the kinematics, and they come with a triad. Flexible flat feet, tight cords, leads to an altered gait, which gives them back pain, knee pain, and hip pain. So when you have this alteration in triad, you can imagine that everything is painful, and activity that at this age are fun stop being fun. The treatment of flexible flat feet, it's simple. I know the literature says 95%, but I would say about 99% of children with symptomatic flat feet can be corrected with simple orthotics and therapy to lengthen the calf muscle. They may need activity modification, and weight loss has never harmed anybody. But what happens? So as soon as we put the orthotic, on the right side, the hindfoot deformity is corrected because the joints are supple. On the left, it isn't. So therefore, when a child comes back after orthotic treatment and having said that it's not helping, one of two problems can be going on. Either the orthotics and the prescription is wrong, or they're not wearing it enough, or the joints are no longer supple, and hence the orthotics are not working. Which brings us to, what are surgical options? Invariably, most children will require some lengthening of their tight cord if it hasn't been stretched, and then we can consider hindfoot procedures and forefoot procedures to heel shift or lengthening the medial column of the foot. And we can also consider arthroresis, which blocks abnormal subtalar movement. So here is a child who's had both a heel shift and lengthening of the calcaneus, and you can see how the kite angle has improved, as well as the Meary's line, the talonavicular joint has improved. Or one can only do the calcaneal lengthening, and that sometimes improves it. So it's basically assessing how bad the hindfoot is in relation to the forefoot that you decide whether you do both hindfoot and forefoot surgery. What about the arthrodesis? Because there is this is one of those dividing things where the podiatry community in America love it because there's a simple extra-articular procedure, and the orthopedic foot and ankle surgeons hate it. I'm not sure. I put 3 of these in, and they work brilliantly. There are issues where you need to know whether yours is an axis altering, whether it's an impact blocking or self-locking thing, but when it's selected correctly, it works. There are problems. The child will outgrow it. If you don't put it correctly, it will damage the joint, and occasional ones can pop out. But there is no doubt that it is an important and useful adjunct. Which brings us to these unfortunate less than 1% of children who have structural or pathological painful flat feet. The commonest cause for us is the tarsal coalition and the neuromuscular disorders. But and these children require different agendas. So the tarsal coalition is the commonest foot and ankle pathology that affects children, and half the time it's bilateral. There is a heritable component, but don't forget that it can be through trauma or inflammation. The calcanevular coalition is and the calcaneal are the commonest. Of almost 8 to 9 out of 10 will be these. In the past, CT scan was the investigation of choice, but now we have recognized that there can be fibrous unions. So MR is the gold standard. And the treatment is very simple, especially for the calcaneonavicular ones, is excision. The commonest problem with these are inadequate excision, so make sure we get to see this tunnel view and ensure that there is adequate excision and that the subtalar joint is supple on table. The talocalcaneal ones can be a little challenging because of the degree of variation in amount of fusion. And there's debate as to whether if there's more than 50%, whether one does fusion or not. I have excised up to 50%. One of the things I found very helpful in finding the coalition is to actually introduce a probe from the sinus tarsi on the lateral side, and it takes us straight into the coalition, and this has helped me on a number of occasions. And then we can, in my days, children weren't fat enough, so we had to put in wax. But now you can put fat in them. Now, this I have not done, but this is an interesting concept that if you have a large coalition, you do not go for fusion, you correct the deformity fore and aft. And this is fairly logical, but you have to understand the child has already done fusion. Why is the fusion symptomatic? Well, the fusion is symptomatic because there is a deformity. So if we correct the deformity across the fusion, we have improved we should be able to change the symptoms, and it works. So you do the heel shift and you lengthen appropriately. You do not touch a large coalition. What about the role of fusion? Well, it's extremely rare, and it's usually essentially done to improve the position of a foot, either in a congenital vertical talus or in the unfortunate cerebral palsy situation, because this then allows footwear and may allow the child to walk. Thank you.
Thank you, Dr. Arshad, for an overview of the pediatric flat foot. So any questions for Dr. Arshad?
For flexible flat feet or flat foot, have you tried sinus tarsi implants? It's a very simple procedure which you can do even local anesthesia. Yes. Hello.
I think you didn't hear the question. Sorry, we can't hear you. Dr. Arshad, your mic. नहीं, इनकी आवाज नहीं आ रही.
Hello?
Yes, now we can hear you. Okay.
Yeah. So as I said in my presentation, yes, I have used the arthrodesis, the sinus tarsi implant. I have used it on 3 occasions, mainly because the parents did not want to contemplate osteotomies. And the child was symptomatic and they had big exams coming up. So we agreed that, that the sinus tarsi will improve the symptoms, but we do need to understand that there are risks. So yes, I have used them. It works brilliantly, but there are issues. You have to select the implant appropriately. You have to size it, and you have to understand that you will have dislocation. I have not had a dislocation, but I have come across dislocated implants.
Well, if the implant is snugly fitting, then there are no chances of dislocation.
Correct. Correct. I mean, you still have to do the correct operation. The fault of an implant, but remember, the child is still going to grow. The feet are going to grow. The implant is a finite size. So, and you have to put it correctly. I don't have a problem with the implant, but I don't. But we also have to understand who we are, when we are going to put it in. So you're going to put it in around 10 to 14-year-olds. That's for me, that is the age. I mean, I would hate to operate on a child under the age of 10 for flat feet,
Exactly.
apart from coalition.
Exactly, the indication is when the child is close to maturity, and that is about 10 years.
But one of the problems is that if you go that far into maturity, you do not correct the bony shape. So if you have a little problems with the bony shapes, with the shape of the bone, if you do it a little earlier, the bone will remodel as well.
Okay, one more thing. In your experience, do the orthoses or the shoes which we recommend for the flat feet, do they help, or it's just a placebo effect?
So the physics is very simple. We need an instep. So all shoe manufacturers now do shoes with high arch. They are called instep support high arch. So there is no specific. So I tell the parents not to waste money. Go to any shoe manufacturer and just ask them the same model with an instep.
No, my question is, do these shoes help in your experience?
So they help. You have to understand, the child who doesn't have a problem will carry on. The parents now feel that they have done something. So everybody gets helped. If you improve the physics and you put the heel in the correct place, the child can run a little better.
And normally, till what age we can recommend the shoes?
So in fact, as we get older, I have another subgroup of patients, the elderly, the middle-aged ladies, who after the loss, estrogenic withdrawal, you start to see that their feet also start to sag. So in fact, the age, you may need an instep throughout life.
Thank you.
Okay, thank you. We have a question by Dr. Mohsin. Yes.
Good evening, Mr. Khalil. Thank you for your lovely talk and sharing the experience. A quick question. I know up to the age 10, what about the adolescent patients which are, close to the maturity and not fully mature? After excision of the bony coalition, do you have any augment with the osteotomy, sliding osteotomy or something, any additional procedure? And the second additional to this is, what about the fibrous coalition? Thanks, Khalil.
Yeah. So I come back to my original question. Why is partial fusion painful? When we're trying to fuse a joint, So say you folks were talking about ankle arthrodesis. We only need 30% of the joint surface to be fused for it to be asymptomatic. So in any joint, hip fusion, knee fusion, ankle fusion, you only need 30% of the total surface area. And in large subtalar fusions, there's already 50% surface that is fused. So why is the child having symptoms? They're having symptoms because the physics is wrong. There's a deformity. So we then need to look at the hindfoot and the forefoot. And as you said, so even if you take out the bar, if there is still a deformity, the child will still be symptomatic. So I can only remember one patient in whom we did an excision, but the subtalar joints were still stiff. Remember that if the subtalar joint is stiff, you haven't developed the muscles to move the subtalar joint, and they will take a little while. But if it's stiff to start with, the muscles are not going to work. So we had to do a small heel shift to bring the heel to neutral. So yes, if you leave the coalition for later on in life, then you're going to not have the muscle. So you have to look at the deformity, and you may have to augment with hind and forefoot procedures. And fibrous union, I haven't done that many, but the fibrous excisions I have excised, the commonest cause for the problem is inadequate resection. So I just make it an absolute point to get the sinus tarsi view and make sure that there is nothing. And then on table, the subtalar joint has to be supple. You have to be able to move the subtalar joint before the end of the procedure. Does that answer the question, Wilson? Sorry, I get very excited.
No, thank you very much. We have two more questions left. First, Dr. Rizwan. Please, can we keep it short because we are running behind time?
Yes, sir.
Yes.
Dr. Arshad, Assalamu alaikum.
Well, start.
So, I'm Dr. Rizwan. I have done about 12 pro-stop subtalar arthrodesis screws in Pakistan. So I have got two questions for you. First, what is your experience regarding the sinus tarsi pain? So most of these patients are school going, and they usually are non-compliant with the pain which happens for the first 2 weeks. So what is your say on this? And secondly, I have noticed that the bigger the size of the sinus tarsi screw, if you are putting, the more the chances of dislocation. So just wanted your point on it.
Yes, sir. You have to be very careful. I had to go to the sinus tarsi implant that I had to actually go to a cadaver lab to understand what size effectively, because if you think about it, when we do heel shift, okay, if you do not go up to 1 centimeter or at least 10 millimeters of heel translation, you actually do not correct the Achilles. So the Achilles still remains in valgus. So my point is that it actually really depends on the implant you're using. There are 3 different types of implants, and they all work slightly differently. So please be 12 is 3 times more than that I have put in. So you have more experience than I have clinically.
So we have pro-stop. So we use pro-stop.
Yeah, pro-stop. They will have pain. They will have pain because you have to understand that there are 2 things. The muscles that move the subtalar joint haven't developed yet because the hindfoot has been sitting in valgus. So they will have some sinus tarsi pain, and just persevere. One of the things that therapists will do is make them start doing aggressive therapy. So stop that. Just learn to walk first with arm supports, and it will get better. So yes, all the 3 or 4 that I've done, they all had initial pain, and I was scratching my head thinking, God, I've got this wrong. But they all got better.
Okay, thank you. Last question.
Thank you, Dr. Saab. You are a nice talk. I have a question that mostly children came at the toddler's age. Just they walk, and the parents notice that they have got the flat feet. what measures we can do at that age to prevent it further, and also to fulfill or to satisfy the parents also, that what we have to do at that time.
So I'll go, thank you. So I'll go back to my original thing. This is an exercise in detection and communication. So the line I use when there is no structural problem with the feet, I have made sure that there is no structural problem with the foot, and I'm confident that this is just pure flexible flat foot at any age. The line I used for the parents is that it's like having a long nose. If you have a long nose, there are some glasses that you can't drink water from because it interferes, right? But it's not a medical problem, right? You just have to change the glass that you can drink water with. So having a flexible flat foot is not a medical problem. And there are some activities that children can't do. So here is the dynamics that starts happening with the family. The parents want the child to do things, and the child uses the flat foot, do not want to do those things. So that's what we need to learn to tease out. The good news about flat feet is that nothing will get worse because there isn't a structural problem. Right?
Can we give some high arch feet to them?
Oh, high arch feet is a different problem, sir. That's a cavovarus foot. So that is a completely different foot, because that is 90% of the time that is an undiagnosed neurological problem, where there is an imbalance between the everters and the inverters of the foot. So you have to be absolutely careful that you're not mistaken. A high arch foot is a completely different ball game, and they will require more help. And in fact, they may require surgery because the orthotic treatment available for them is much lesser. So unless the deformity improves with a Coleman block, then you can give them orthotic. But if it's a hindfoot driven or a midfoot driven cavovarus foot, then you will need to correct that with surgery, because there is no orthotic treatment for a hindfoot based cavovarus foot. So a high arch foot is not a flexible flat foot. Sorry, my talk I didn't know I had to include cavovarus foot.
No, you didn't have to. I think this flat foot itself is a very big topic, and thank you for covering it so nicely in such a short minute. There's a lot of interest in the hall in the topic, but unfortunately we are limited by time, so we need to move on. Thank you, Dr. Arshad Khalil, for this great talk.
Thank you. Thank you very much.
So the next talk is, we will continue with this flat foot theme. So the next talk is non-operative management of adult flat foot by Dr. Arshad Qamar. Dr. Arshad Qamar is an orthopedic surgeon with a special interest in training in foot and ankle from UK. He's practicing in Karachi.
Thank you. Assalamu alaikum. Thank you, Tashfeen, for inviting me over to give this small talk today. So I tend to manage most of the adult flat foot non-operatively, and I go with you along the principles of treatment. Can we move to the next slide, please? Thank you. So as we all saw, it's very common to detect a flat foot even in adult population. And most of the time, the adult flat foot is an acquired deformity. It's got nothing to do with the congenital problems. Usually, adults do come up with tib post insufficiency. They start to develop pain, and then you notice that they've got a flat foot deformity. So what is the pathology here? We all know about it. Mostly, as I said, commonly it's the tib post insufficiency, but then also there is failure of the ligaments and the capsular structures of the foot. There may be a tight heel cord there. There may be an imbalance between the peroneus brevis and the other tendons, which may lead to such deformity. So these are the intrinsic factors. Some extrinsic factors we know of: trauma, cortisone injections, obesity, diabetes, and hypertension. So treatment depends on the symptoms, age of the patient, level of the activities, and whether or not the foot is flexible. Early diagnosis is important. The sooner you diagnose it, the earlier you start the treatment, the better results you get in way of pain management. Goals of treatment, as I said, to minimize the pain, eliminate pain, improve rear foot alignment, and prevent progression of the deformity. So this is how we proceed with the management, by immobilization, either with a boot cast, below knee cast, or a patellar tendon bearing cast. I use orthotics routinely in my practice. The one on the right, the UCBL, is the commonest orthotics that I use for flat feet in patients. If these are not difficult to find, but again, I mean, they're not readily available. Sometimes they have to be custom made. For more severe deformities, you can use one of these as well, with or without the shoes, but they do help and they do control the flat foot. The other thing that I've noticed that with these orthotics, people do get, and a flat foot, people have difficulty in walking. For that, if we produce a rocker bottom shoe, or we give them a rocker bottom shoe, they find it easier to ambulate, to walk. Physiotherapy is important. As I said, tight heel cord is one of the reasons where they would be getting a flat foot. So stretching, all these exercises to strengthen the muscles, they do help improve the symptoms. So in conclusion, conservative treatment works well, manages pain and progression of flat foot deformity. Early detection is important, and we can prevent the dysfunction with orthotics. Thank you.
Thank you, Dr. Arshad, for covering the treatment which most of us will give the patients always at the start before deciding to go on to surgery. So this is a very important aspect that has been covered now. In the interest of time, I will move on. We can have some questions after a few more of the talks. The next talk, I will invite Dr. Rizwan Haroon. His talk is on ankle arthroscopy. And following that, we'll have a talk on hallux valgus management by Dr. Haroon Majid, inshallah. First, Dr. Rizwan. Yes.
Assalamu alaikum. So I am Rizwan. So I have no conflict of interest. So ankle arthroscopy, knee और shoulder तो सब कर रहे हैं आजकल. So ankle and wrist भी है. Ankle arthroscopy is a emerging field at this moment of time. So it was established in 1931 when first time ankle was scoped. But Dr. Berman, he was not able to see. So later, Dr. Tagaki established a new arthroscopic system, and he was able to do arthroscopy of the ankle. And this is the guy who is the father of ankle arthroscopy, who invented first time result, Dr. Watanabe. And he is from Japan. He was from Japan. And the arthroscope which was used was from Olympus. So आज तक Olympus के scopes आते हैं. So first time ankle fusion with scope was done in 1985. So it is not that young. हमें नहीं पता. So he's a father of modern day ankle arthroscopy. So he's Professor Van Dijk. So I had the chance to meet him in Amsterdam foot and ankle course. He treated the famous Cristiano Ronaldo, and he has got a T-shirt from him, and Cristiano has written when, and he has changed the modern day perspective of ankle arthroscopies. So ankle foot and ankle platform है आप Google पे डालेंगे तो you can easily see इसने बहुत अच्छी videos and everything has been there, and they conduct every year a course which is very very good. So certain indications, जो ankle arthroscopy is not like knee arthroscopy. So there are very good and limited indications. Most of the time, bony and soft tissue impingement. Bony में talar, osteophytes, distal tibial plafond, osteophyte, ankle dorsiflexion restricted है, तो you can go in and just shave off. OCD talus is one of the major area of interest for my kind of a guy who does microfractures. Ankle instability, Dr. Majid will be talking about this. So Jordi Vega is the father of lateral, all inside lateral ligament reconstruction. It is good thing, but involves too much of implants, not available at this moment of time in our part of the world. So I do it for my ankle fractures. I do a dry scope after reduction. It's very easy. You can use a knee scope. मैं आपको बताता हूँ. Dr. Sohail ने बताया arthritis के लिए it is a standard, but in our part of the world we have got too much of deformity. So fusion with arthroscopy has got its limitation. You cannot correct deformity. हमारे पास बहुत अच्छे ankle नहीं आते. जिस तरह हमारे पास knee arthritis early नहीं आते ना, उस तरह हमारे पास we have got too much of deformity. You cannot do it. You will create a problem. And chronic synovitis. So bony impingement, ये आप देख सकते हैं. There is a X-ray showing this, and it's a very simple procedure. You can done under blocks or significant improvement in pain, movement. Osteochondral lesion, we all do this. Those who does ankle arthroscopy, it's very easy and very rewarding. Lateral ligament repair, I have tried many times, but I am unsuccessful because उसके कुछ implants अभी नहीं है, and a small incision is able to take care of this. So then Dr. Jig established a posterior ankle arthroscopy. Prone position के अंदर you can do a subtalar fusion. Ankle impingement, posterior ankle impingement ostrigonum, you can easily take it out arthroscopically with significant improvement in symptoms. Tarsal tunnel syndrome, loose bodies and arthrodesis. You can do a hindfoot arthrodesis with this thing. So you have to do the prone position. So this is PASTA, posterior ankle arthroscopy. इतना होता है कि आप उसको अगर करें इसमें केवल आप पूरा. So difficult judgment for us. So I have this keen interest in tendonoscopies. Dr. Tashveen is my partner in crime. He does good tendonoscopies. Peroneus longus of brevis का tear बहुत common है. Lateral ankle sprain के साथ मरीज आता है, 4 महीने हो गए, 6 महीने हो गए, pain नहीं जा रहा. So there is a tear of the peroneus brevis / longus. Most of the time brevis is the culprit. So ये स्कोपी आप कर लें और देख लें, ये आपको पूरा peroneus longus दिख रहा है, साथ में brevis भी है, and it is diagnostic. अभी तक all inside repair technique दुनिया ने नहीं इजाद की. The future direction is this thing. So we have the luxury of doing endoscopic Achilles tendon repair. It's very good and very easy, but we have to do certain number of cases to say that it is easy. तो वूंड कॉम्प्लिकेशन कम होती है, और सूरल नर्व अगर आपको एक दफ़ा समझ आ जाए ना उस स्कोप से, so that will be saving. So setup, I don't do it ankle distraction. So you can do it with a bolster under the knee joint or supine. I do supine. Patient is on the edge of the table, and you can do dorsiflexion with the help of your tummy. So you have to have a big tummy for without distraction. So you don't need any special kind of scope. So I do most of my ankle scopes with a 4 mm scope, 30 degree, but for tendonoscopy, you cannot do it with a 4 mm because it will damage the thing. So if you want to go posterior from anterior, you have to have a small 2.7. पीछे से भी आप 4.0 का कर सकते हैं. It depends upon your training. So I was trained on 4 mm scope. So ये पेट से भी traction दे सकते हैं if you want to, but I do the other way. So these are the anterior medial, anterior lateral point. ये जो है ना ये, this is the point of contention. So this is a superficial peroneal nerve, and it is commonly damaged when you use an anterolateral portal, and the patient will kill you coming again and again to the clinic with neuroma. So इसी वजह से all inside के लिए passport आया हुआ है, तो उसमें nerve बच जाती है उसकी टेक्निक की वजह से, जो इंस्ट्रूमेंटेशन की वजह से. So this is the thing which you have to mark before you start anything. And it is easy. You do plantar flexion and inversion, and it is most of the time मेरे जैसे मोटे आदमी में भी वो दिख जाती है. और अगर आपको ना हो तो you can take it with the help of a pen, the surgical pen. You roll it, so you can see that rubbery thing under the marker. So ankle arthroscopic has progressed significantly in the last 25 years. Improved diagnosis, the anterior से लेकर posterior तक जा चुकी है. Now the next step is कि और इसको मज़ीद हेलिक्स के लिए भी लोग कर रहे हैं, MTP fusions के लिए. So one important thing when Dr. Jig said to me that the success of ankle arthroscopy lies how good we are with the knee and the shoulder scopes. So अगर वो grow करेगा तो ये भी grow करेगी. So thank you very much.
Thank you, Rizwan, for telling us one of the emerging techniques which we need to develop here in Pakistan more and more, inshallah. So the next talk is by Dr. Haroon Majid. He is a foot and ankle surgeon working in Manchester, UK. He has been supporting us in our activities through online talks so far, and this is the first time that we have managed to get him across here to give us a live talk in person. Dr. Haroon.
Thank you very much, Dr. Tashfeen and Dr. Rizwan, for your kind invitation. It is an honor for me to come here on this forum and share my little experience here. Can we have the Helix Valgus talk, please? Thank you. While we are waiting, can I ask the audience how many of you do bunion surgeries here? Any correction and use chevron or scarf raking? What is the trend here? What osteotomies are used? Say again? Okay, so Lepidus more than the, okay, right.
We have a couple of more people. Dr. Muhammad Inam is here. Muhammad Inam. longer. But Dr. Dilbagh was here a while ago. So if Dr. Dilbagh is not here, then this is the last talk. So if you can just bear with us a couple of minutes. I don't know. The file somehow got deleted. He's just uploading it. Yes, we can continue with our discussion on any of the previous talks. Ankle arthritis, flat foot, children, adults. No. Or collateral ligament. Does any of you do ankle lateral collateral ligament surgery here in Pakistan? Case? Okay. Yeah, Dr. Suhail has a case to discuss. If we have time, we'll go over that, inshallah. Yes.
Okay, sorry. So trust me, these IT issues are not any better in the UK as well. So these things happen. So this is working. So I work as a foot and ankle consultant in central Manchester in one of the busiest major trauma centers. And our trust currently is the largest in the country. And my practice is primarily foot and ankle on elective side, plus some general and major trauma on the trauma side. So I'm going to talk about hallux valgus, or bunion in simple words, which is one of the commonest problem that we see in our elective foot and ankle clinics. Patients present in different age groups with a spectrum of the severity of deformities and variation in their symptoms as well. So it would make more sense if a mild to moderate deformity has mild to moderate symptoms and severe deformity has severe symptoms, but in practice, it doesn't work like this. For example, a younger person with a mild deformity may have more severe symptoms than a severe deformity in an elderly person. So this person on that picture might not even come with the bunion symptom, but may come with the second toe symptoms, and bunion is completely asymptomatic. So that makes the management more difficult. So a bunion has been present throughout the life of that person, for example, from their teenage or early 20s. But why all of a sudden it becomes symptomatic? Because it's not the bunion itself, it's the associated effect on the whole forefoot which cause progressive symptoms. A typical patient, it's more common in females, about 70 to 80%. Family history is usually present in these patients. And the progression of the deformity and the symptom severity aggravates by certain factors of flat-footedness or hypermobility in these patients. And as the bunion progresses, the dominoes effect on the lesser toes causes hammer toe or other toe deformities as well, which may require additional treatment. Shoes, high heels, they are typically blamed for it, but they are secondary factors more than primary factors in females. But if the toe box is narrow and the person is predisposed with some presence of bunion, that may aggravate the progression of the symptoms or the deformity. Clinical assessment, this is a typical picture of a bunion in an elderly person. You see a prominent medial eminence which causes pain because of the shoe wear rubbing on it, and sometimes in severe cases it may even ulcerate, and then your surgical treatment gets compromised because of infection. It is important to assess the symptoms of the first MTP joint, because that may be a coexisting pathology in some of these patients, as the joint may be subluxed. And the lesser toes, and the usual routine examination of your rest of the foot and assessment for hypermobility. Standard plain x-rays, AP and lateral weight-bearing views, which show you the presentation of the joint as well. Now, some surgeons are very much fixed on these angles, and they check it before and after correction. I personally don't, because there is no evidence to suggest that if you correct the angles, that has a correlation with the outcome of your surgery. But for academic reasons, we all must know these different angles. And these are some normal values, depends which book quotes these, and there is some variation in different references. The first line of treatment is always conservative. However, in a tertiary referral center, the conservative treatment is usually already tried, tested, and failed for several months or years, and you are talking directly on to surgical treatment. But it is important to explore what specific measures have been tried and how long for, and what was the compliance of it. Although conservative treatment will not be curative, but it can manage some of the symptoms in a selected group of patients. And these are usually shoe wear supports, insoles, and accommodative footwear with wider toe box. Orthotics may have some role, and there are some specific bunion supports available commercially, which may sometime improve some of these symptoms. So once non-surgical treatment fails and the symptoms are progressive, which are affecting the quality of life, then there is a good role of surgery in these patients. So this is not for cosmetic reason. Surgery is only justified if there are clinical symptoms which are enough to warrant surgery and not for asymptomatic cosmetic reasons. Surgical treatment is a combination of bony and soft tissue correction, a combination of osteotomy, lateral release, and medial tightening of the capsule. And someone narrated the bunion surgery very wisely, as it is similar to walking uphill on a steep path and you're trying to avoid falling on either side. And that's exactly what the bunion surgery is, because you can easily overcorrect it or undercorrect it. So it has a certain learning curve that you have to learn and practice and improve from your own practice as well. The goals of surgery are to improve the angles, yes, not academically by measuring on a radiograph in theater, but more with your own subjective assessment of your deformity correction. So firstly, the medial eminence is resected. Then depending on what osteotomy you're using, you have to achieve sufficient correction of the deformity and then correct the soft tissues on either side, and also to minimize the impact on the first MTPJ, which may already have some degenerative changes. There are more than 100 surgical procedures described in the literature to correct the bunion. These are certain names which are commonly used, and in the UK, the commonest are chevron and scarf and Aiken osteotomies, although some other handful procedures are also used. The proximal or the distal or the shaft depends on your personal experience, and in severe cases, the osteotomy may not be a viable option, and you have to address the first MTP joint by a corrective fusion. Lepidus in the northern part of the UK is not very popular. In south, it probably is. In the Europe and in America, it is used, but during my training, I've only done handful cases of lepidus for certain reasons. The main difficulty with that is if the first MTPJ is already arthritic or becomes arthritic, then you will fuse it and the medial column becomes very stiff and patient will never be thankful to you. And then what happens if the IPJ becomes arthritic in future? There's no end to it. So in my mind and in my training, it is like burning a bridge, and you have to avoid if at all possible. So an ideal osteotomy, this is a typical exam question as well, and the candidates come up with the names chevron, scarf, and Aiken. But an answer should be that ideal osteotomy is the one which is technically easy to undertake, it is reproducible, it should be stable without any risk of displacement, and you can maintain the length and the mechanics of the first metatarsal by avoiding dorsiflexion of the head unnecessarily. It should be versatile to correct all your angles and without compromising the circulation and avoid the risk of AVN, and should have the least risk of recurrence. In practice, such an osteotomy may not exist, but there is a closest match which we can work on. Chevron osteotomy is usually reserved for relatively younger patients with relatively less severe deformities, mild to moderate. It is a V-shaped cut where the the plantar limb of the V is left longer in order to achieve more stability. Some surgeons use just the soft tissue repair to rely on, but a single screw is a common option that is used to make it stable. We aim for shift of about 0.5 centimeter, and you have to be careful in releasing excessive amount of soft tissues because that can risk AVN of the head of the first metatarsal. It is inherently stable, and if you add on a screw, it adds on to stability, and you can let them wear with a rigid sole shoe, and it achieves a decent result. For moderate to severe cases, scarf and Aiken is considered a gold standard in the practice in the UK, and it is widely practiced osteotomy. It is based on the principles of a carpentry procedure. You make a cut and you slide one part of the bone onto the other and fix it with screws. It is a very versatile osteotomy because you can correct in all three planes by addressing the translation, rotation, and the length of the first metatarsal. You can shorten the first metatarsal as well if required to offload the joint, but you have to be careful and avoid excessive shortening because that will change the dynamics of the forefoot and will cause transfer metatarsalgia. Usually done through medial incision. The lateral release can be done through the same by reflecting the soft tissue flap, which does not cause any issues. But if you prefer, you can do a separate incision in the first web space as well. And what do you release laterally is a suspensory sesamoid ligament and adductor hallucis. But again, you have to be careful in your lateral release and avoid any excessive instability of the joint as well. After that, you do the medial eminence. Again, be conservative. You can always take more bone off if required, but you can't put the bone back if you have taken excessive medial eminence off. And followed by this, you do a Z-shaped cut, which is the cut in the bone is actually on purpose. I put this picture because that's not very accurate cut. The blue line marks what it should be with the cut slanting down along the shaft of the first metatarsal. And typically 2/3 of the shaft is divided. You can do a modified scarf, as it is called, which is shorter than this for less severe cases, and that can give you more stability as well. And then the dorsal limb, the other parts of the Z are at about 60 degrees angle. So after that, you slide the osteotomy and achieve for as much as you need, 40 to 50%, and assess subjectively on table. Some foot and ankle surgeons do use X-rays in theater as well. Again, there is no evidence to say if the use of X-ray provides any better correction or the long-term outcome. It's a subjective choice, and the counter argument against the use of X-rays is that we do use radiations a lot in our trauma surgery, so if we can avoid anything that doesn't have any evidence, then it may be better to avoid. After the slide, there is a set of instruments which is simple, basic, pointy reduction clamps and a bone holding forceps, and this that's the wrong end of the body for us. This kit is typically used. It has just a handful of instruments which we use specifically designed for this. It's available from Ortho Solution, from Wright Medical, and from Synthes as well. After enough slide, we use with 2 screws, which are typically 3 millimeter cannulated screws, which provide enough compression, and it's really, really stable osteotomy on table. And then after that, you take the medial shelf off. Okay. And again, you have to shift in the right direction rather than the wrong direction, which wouldn't help. Aiken is a cherry on the top, basically to improve your overall correction of the deformity. In relatively less severe cases, you may not need it, but again, my theory is be consistent with your approach, select one operation that works for your patients, and consistently perform. So my standard combination is a scarf, an Aiken osteotomy, and lateral release, and medial tightening of the capsule. If you've done it well, in the end you get a really good correction like this. And post-op care and wound care is extremely important. If I let my registrar do the operation, I make sure to close the wound, because then I don't blame him in 2 weeks' time if there is some problem. And the pictures showed self-retainers and other instruments, but I do gentle tissue handling and avoid anything unnecessary which is not needed for foot and ankle surgery. So again, a nicely done operation gives you a really good correction, which patients like it, they get good results, and from here to here you can achieve a good correction. So there are lots of studies available in the literature, but again, the quality of studies isn't brilliant, and you have to be careful in analyzing their outcomes. So one of the Cochrane review that showed there was no evidence to support the conservative treatment. It's more like a homeopathic, but again, there are some patients who may not be fit for surgery, so you can at least have some options for them to correct some of their symptoms. There is no recommendation for a single choice or a single name of osteotomy. Depends what you've learned, what you feel comfortable practicing, and what works in your hands for your patients. That's the important bit. Overall, more than 85% good satisfactory results, and we always have some patients who will never be happy with anything that we do for them. So the osteotomy of choice for mild deformity, chevron has a small role, but mild deformity, you have to assess their symptoms. That is the bunion the only problem that they have? There may be other problems that may not be looked at. And for mild problems, you don't really need surgery, but there are some patients who have enough symptoms to warrant. So careful assessment is the key. For a typical moderate to severe deformity, my choice is scarf, Anakin, and lateral release with medial capsular tightening, because it is stable, it provides excellent correction, it is very versatile, there is no need for restricting the weight bearing afterwards, it doesn't compromise the circulation, and it is reproducible with a sufficiently learning curve with it. It's not technically easy, you can easily mess up with it. I have done a few cases where I have not done as well as I wanted, but again, there are ways to correct that as well. And the more you do, the more you learn from your own mistakes. For a very severe deformity, which has already crossed the barrier of requiring scarf and Aiken, corrective fusion is the right option. Yes, Lepidus has a role, but depends on your experience and your learning. Complications occur in anything that we do, and iatrogenic hallux varus can occur, so you have to be careful in your soft tissue correction and tightening, and soft tissue release laterally. Metalwork usually is not an issue, but in some cases where even the proximal most part of the head of the screw is prominent, that can badger the EHL and may require removal at a later stage. Depending on your correction, transfer metatarsalgia can be an issue. Recurrence, the only study that I could find was about 10 to 15% risk of 15 years in terms of its long-term recurrence, but that depends on multiple factors, not just the surgical correction. Flat feet and hypermobility are associated with high risk of recurrence. So even after surgery in these patients, use of appropriate insoles may reduce your long-term recurrence rate. And the other usual complications that can occur in any lower limb or foot and ankle surgery. Very briefly, minimally invasive surgery, I personally don't do it. I haven't learned it yet, but at some point I may learn some of these. In the last 10 years or so, as a British Foot and Ankle Society, they were not very encouraging of minimally invasive surgery because of its own complications. But now the trend is changing like everything else. So there is more acceptable role of MIS in bunion as well as other foot pathologies. There are certain kits which are improving day by day for doing this, and the arguments in favor of this is that it reduces your wound problems, length of scar, overall recovery, overall stiffness, and it can still correct really good deformities if you do it well. However, we don't have enough longer-term data available on these, and they can still be soft tissue problems because of the use of certain instruments. So they are safer now as they were 10 years ago, but still you have to learn it, you have to practice, do a few more cases before you can be confident. and it has its own pros and cons. So in summary, scarf in Aiken osteotomy with lateral release and medial tightening of the capsule is a reliable and effective method for correcting the bunion for moderate to severe deformities. It provides excellent stability and correction and permits early weight bearing with a good function. But just be careful of certain things. Now, last but not least, this is one of my patients. She was 80 years old, otherwise in good medical health, but this bunion was affecting her quality of life. During the COVID time, like everything was stopped, so her referral got delayed and the deformity got worse over 3 years. By the time she came to me, this was her foot. And these were the x-rays with an arthritic and subluxed MTP joint. So in her, I did a corrective fusion with the second toe straightening, which had a hammer toe deformity. And again, not discussing the fusion in detail, but my standard choice is an oblique screw and a dorsal plate, which gives excellent correction and results. And this is 6 weeks X-ray, removal of K-wire. And from here, this is her clinical picture at 10 weeks when she was asymptomatic. She was back to her normal mobility and walking with normal shoe wear. So this is just a bit of a food for thought. We all have our own different views on different types of procedures, but the standard principles remain the same, whether you take approach A, B, or C. If you follow the principles, do a good correction, look after the soft tissues, and address the patient's demands and expectations individually. You will get a good result. Thank you very much for your attention.
Thank you very much, Dr. Harun Majid. Question? We don't have time for question. Only okay. One single question. जी. Afterward? अच्छा, क्योंकि हमें पीछे से प्रेशर आ रहा है कि जनरल बॉडी मीटिंग करनी है, ख़त्म करें अब, लेकिन अभी एक टॉक भी रहती है असल में. डॉक्टर दिलबाग इज़ हियर, सो आई इनवाइट डॉक्टर दिलबाग शाह फ्रॉम पेशावर for his talk on the kidney's procedure.
See Dilbag, folder is there. Okay, Bismillahirrahmanirrahim. Thank you, the organizers, for giving me opportunity to present this brief topic. So basically, this is the Kidner procedure for the restoration of the medial arch after resection of accessory naviculum. So basically, I'm just going to give a brief description of the procedure. As we know that the accessory naviculum is quite common condition, and its prevalence is about 1 in 1,000. So when it becomes symptomatic, so and conservative measures fail, then we are left with the surgical option. In the surgical procedure, the one which is, globally very much famous is the Kidner procedure. So basically, Kidner procedure consists of the excision of the accessory naviculum and rerouting of the tibialis posterior tendon to a more plantar and lateral position to restore the medial arch. So preoperative counseling definitely is because most of these are the adolescents, and the more than the patient, the parents are very much concerned. So counseling of the parents as well as the patient is very much important, and the surgeon has to convey the message that there is the permanent correction of the arch can't be guaranteed with this procedure. However, relief of symptom of the prominent bone, which is the accessory naviculum, and reduction or elimination of the fatigue from arch is quite predictable. Now, what the indication of the procedure? So basically, the indication of the procedure is the excision of the accessory naviculum, which is symptomatic and is not going to respond to the non-operative measures. Now, what are the steps of the procedure? So about 1 to 1.5 centimeter distal to the medial malleolus, skin incision is given, which depends again on the expertise and the familiarity of the surgeon in the procedure. It can extend up to the base of the first metatarsal. Following that, there is identification and separation of the end ligation of these saphenous branches. Following that, there is identification of the tibialis posterior tendon about 1 to 2 centimeter proximal to insertion into the naviculum bone. And then what you have to do, that you have to just de-shelve the accessory naviculum, and you have to take a part of the medial cuneiform along with the tibialis posterior tendon, and have to transposition it a bit, plantarward and laterally. As we discussed already, that there is removal of the portion of cuneiform along with the accessory naviculum, and using sharp dissection and shift it plantarward and laterally as much as possible. Following this, the tendon can be sutured at the apex of the medial longitudinal arch using the periosteum and ligamentous tissue to secure the transposed tendon slip by passing the suture through the holes, or you can drill it into the center of the navicular bone and attach it with that. So depending upon the expertise and the familiarity of the surgeon. Now again, important thing is that try to advance the slip of the tendon while the talonavicular joint should be held in the reduced position and midfoot in the cave of rest position while tightening the tip post tendon. Following that, there should be a meticulous skin closure with the absorbable suture, because following that we are going to give plaster to the patient to keep it immobilized for at least 1 month time. And a well padded cast is given while keeping the foot in to the cave of varus position to let the tip posterior tendon have a healing in a comfortable position. If the patient not very much reliable, so we can extend the cast above the knee level while keeping the knee in the 30 to 40 degree flex position. However, if patient is reliable, so we can give below knee cast However, the patient has to be non-weight bearer in the cast for at least 1 month time. Now, as we all know, being surgeon, we know that whenever we intervene, so there is always risk of complication. So the complication in this case, possibility is if you are going to under resect naviculum, then the pressure symptoms can persist after the surgery, and still the parents can complain of the, foot pain coming from the shoe wear. Sometimes tenderness persists over the middle eminence even in the adults. Same scenario can exist, persist for longer time. To prevent the problem, it is important to remove the sufficient bone and smoothen the remaining surface with the ranger. If the patient has another alternative abnormality, which can include symptomatic flat foot or equinus contracture or tarsal cohesion that need to be addressed simultaneously, otherwise the problem will persist. Now, this is an article. We conducted this study at KPK, and study duration was over a period of 3 years, in which 20 patients were selected, from both male and female gender, and the procedure was performed. The pre-op and post-op measure were the Mary's angle and the calcaneal pitch. And the conclusion of the study was that Kindler procedure is an effective mean of treatment of the patient with symptomatic accessory naviculum presenting with the flat foot. These are references for the article. Thank you very much. Any question? I try to do it quickly because
Thank you very much. So I think we can have questions informally after we close this session. Now I request our panelists, Dr. Irfan Mehboob and Dr. Harun Mojid, to give their final comments about the session, overall session, and then we can wrap it up.
All the speakers, they gave us novel ideas for the management of few problems, especially the flat foot problem. Surgery, foot and ankle surgery is demanding and challenging, and one has to be very careful, avoiding the overcorrection and avoiding the complications and deformities. That's all what I have to say.
It was a really good and enjoyable session. And I think it's very pleasing to know that the amount of work and the extent of work which has developed in Pakistan for foot and ankle is amazing. So I think I want to congratulate all the organizers and all the surgeons who are doing this work with limited resources, because foot and ankle by default is the most complex. Hip is easy, anybody can do it, and even if you put it upside down, it will still last for 25 years, I think. But foot is such a complex structure with like so many bones, joints, tendons and muscles. And there are so many pathologies, and to complicate the matters, there are so many procedures to correct every deformity. Because on a hip list, there is a right hip and a left hip. But I had a list recently with 6 cases, and all 6 were different. And I had more than many ways of correcting everything in those 6 patients. So there's a lot to learn, a lot of learning curve, and so many complex issues that are still not understood. And my final comment on it, which summarizes the foot and ankle surgery, that there are many unknowns that we know that we don't know. But there are many unknowns that we don't know that we don't know yet. And that's what foot and ankle surgery is. Thank you very much.
For the shield distribution, I request Dr. Abu Bakr to please come. Hi, sir, please. So, I would like our previous chair of the Foot and Ankle Forum, Dr. Irfan Mehboob, who was actually the founding chair of the first POA forum that was established about 4 years ago. 10 years ago.
The painless default to be better than the painful practice.
So, हाँ किसी भी ऊपर खड़ा होना.
So we need a painless. You have to walk.
अच्छा मैं कह रहे हैं कि ऊपर खड़े हो जाएं. So the first is Dr. Suhail Yusuf. The next is Dr. Rizwan Haroon. Next is Dr. Haroon Majid. And Dr. Dilbagh Shah. Session. So with that, we conclude our session. Thank you very much.
Let's have a group photo.
Yes, we can have a group photo.
याद जारी होगी आज से प्रांत से सही सही मुंह के साथ डीबी से पहले डीबी के बाद
फर्स्ट इलेक्शन कमिश्नर ऑफ ऑनलाइन वोटिंग
नहीं the first Orthocon organizer late Orthocon without political
हयात अमर हो गया सर आज से 100 साल बाद
आपने एक्सेलेंट कर दी ना आपने आज ये चीज कर ली द डे वन समाज मैंने कहा 3 साल के बाद फाइनल जो आज आपने गेन कर लिया है यार जो आपने आज गेन कर लिया है इसके ऊपर कितना मर्जी आप
The